Good morning. Okay, we're going to get started in a second here. Can you hear? Okay. All right, so my name is Roshan Bastani. It should be on your programs. And I'm a professor at UCLA and also the director of our Kaiser Permanente Center for Health Equity, which hosts this symposium every year, and we'll talk a little bit about that. This year, we're going to talk about alcohol and health, as you know. Before I move on, I want to say that this conference is a collaboration and co-sponsored by Kaiser Permanente, the UCLA Johnson Comprehensive Cancer Center, as well as the UCLA School of Public Health. So we've been hosting this conference, as you can see, number one up there, since 1999, many years. Many different topics. For example, number 7, obesity, healthcare reform, environmental health, and then this time, alcohol and health. And today we're going to talk about understanding individual, community, as well as societal impacts. We have a wonderful, broad program. You will hear many different perspectives and viewpoints, not just from us academics, but also from the community. This is very important, and we'll talk about that a little bit. As you know, this is a very important topic, very timely, and here are just some of the headlines that have been appearing the last few years about this topic and its effects, again, on the individual as well as society. And a lot has been written about this in the popular media, elsewhere, but also in academia, both nationally as well as globally. This is not just an LA or a national issue, it is a global issue, as you will hear about all of this today. So I told you I'm a professor, right? And a lot of us are, who are members of our center. And what do professors sometimes do that students do not like? Today, it's going to be a pop quiz, okay? A pop quiz. And to administer our pop quiz, we have Andrea Chirino, who is one of our amazing health educators. Many of you may know her. And she is going to help us do this pop quiz.
Thank you, Dr. Bastani. Okay, everybody grab out your pieces of paper and pencils. We're gonna do a pop quiz right now. Okay, I'm just kidding. But we are going to go ahead and get started with a little trivia game. A trivia game on alcohol, just to, warm up our brains a little bit. So give me one moment. Okay, so let me see.
You guys are spared, there's no pop quiz. 1 second, sorry, we've been having some issues with this morning. Yeah.
On your phone or somewhere.
They're there.
It's just here.
So we won't have the fun part of the activity where you guys get to Mentimeter check in. Unfortunately, it's not connecting, but we just can't show it on there, but just have the questions in front of us.
Okay.
So not a technology quiz, but Andrea will lead you through the questions and answers.
Okay, so I'll go ahead and read out the question, and then we can just do a show of hands. I'll give you the answers. or not the answers. I'll give you the options and then y'all can just raise your hand for which one you think it is correct. So for our first question, our statement is, it is safe to drive after just having 1 or 2 alcoholic drinks. So do we agree? Raise your hand if you agree. Raise it proudly. Okay, got a couple. Somewhat agree? Raise your hand, maybe, somewhat. Okay, got a couple more. Okay. What about disagree? What do we think? Okay. We got some responsible people out here. The correct answer is disagree. Okay. All right. Our next question, I like this one. This is going to be a true or false question. So, alcohol warms your body and helps prevent hypothermia in cold weather. Do we think this is true? All right, a little bit, something to warm us up. Okay, I got a couple ones that are about false. Oh my goodness. All right, we've got some well-knowledge people out here. Correct, that's true. Okay. Our next question. I'm going to read out this question and then have some answers afterwards. Which of the following cancers in alcohol is which of the following cancers is alcohol not associated with? So is alcohol associated with stomach cancer, melanoma cancer, skin cancer, prostate, breast cancer, or do we think that alcohol is associated with all of them? All of them? Okay, correct. Got 3 for 3. Y'all are passing this pop quiz. Our next one. The 2022 NSDUH states that 29.5 million people aged 12 and older in the US had an alcohol use disorder in the past year. Of these people, how many got treatment? Our options are 5%, 10%, 15%, and 20%. How many of y'all think it's 5%? Okay, got a good handful. 10%? What do we think? Okay, 15? All right, what about 20%? Oh, okay. Well, for my folks that said 10%, you guys got the correct answer. Next one. According to the 2022 National Survey on Drug Use and Health, what percentage of youth aged 12 to 17 reported drinking alcohol at some point in their life? We've got 12%, 17%, 22%, and 37%. How many of y'all think 12? Okay, 17%. Okay, a little bit more. 22? Okay, how about 37? Okay. My 22%ers, you are correct. Okay, so thank you all for this brief little trivia. It seems like we've all got some good knowledge on alcohol, and I hope you enjoy the rest of today's lectures and talks, and hopefully we can all increase our information on alcohol. Thank you.
Okay, thank you, Andrea. And she did very well, and you can see how bad professors are at technology. Okay, so before we move on, I just want to tell you a little bit about our center that for those who may not be familiar, we are the Kaiser Permanente Center for Health Equity, endowment from Kaiser. And what we do is partner, collaborate with communities, community organizations to mitigate disparities. So this is not about finding where the disparities are so much. We pretty much know almost all health disparities have or are caused by upstream factors that are social factors, such as income, education, the environment you live in, et cetera. So we don't spend as much time on that. What we do spend a lot of time on is conducting research that can mitigate the disparities, do something about the disparities. So we're essentially a research center. We're in academia. And at the bottom here, we conduct community-partnered research. We disseminate the research findings if they're positive. They're not always positive. We try to scale up interventions that are effective. And in addition, we conduct a very wide range of community outreach activities and programs. Andrea, for example, is one of our key staff members who does that. Also like to introduce to you the members of the center. I'd like the associate directors to stand up if they can, and Ernesto. So I'm the director of the center. We have Doctors Allison Herman, Beth Glenn, Fola May, Jackie Casillas couldn't be here today, and our wonderful Mr. Ernesto Sosa, who directs our community programs. I'd also like, we have, I don't know how many faculty, 50 or plus faculty in the center, would like to acknowledge a smaller number that were really key in helping us host this today. And none of the work would be possible without the amazing, talented, dedicated staff that we have, and they are listed here. They are highly qualified for the work they do, and we would not be able to do anything without them. And if you're here, please stand up. I'd like to acknowledge you. They're very modest, but and I can tell you they're multi-talented because Nayab here, who is actually our health educator, is also a wonderful photographer, and he's taking our photographs today. Thank you. And because we are an organization that partners with community, we have a very active, robust, highly qualified community advisory committee. I don't know how many of you are here today, but please stand if you are. These come from organizations all over Los Angeles County, and we thank them very much for their input in everything we do. One key aspect of our center that I'd like to bring up today is that we have a community seed grant program where we provide modest amounts of money to community organizations to do health equity related work that is important to them. We don't tell you what to do. We ask you to tell us what you would like to do that would help the communities that you serve do better. And these are just some sites where we have provided seed grants and some of the topics. And I want to bring to your attention that the 2024 announcement is coming soon, and we encourage all of you to apply. Just as context, before we get to our first talk, in 2023, the World Health Organization declared that no level of alcohol consumption is safe when it comes to human health, 0, okay? It's a big difference than some of the guidelines you hear from professional organizations, what you see in the media, that, you know, wine is healthy for you, all of that stuff. You will hear something about this today as we move through the day. And on the left, again, there's more detail coming in other talks. On the left here, just an example of some of the organs that are affected by alcohol, things that people don't even think about, like the bone. How many knew this? Okay, so it affects all of our systems practically in profound and not very positive ways. It also causes immune dysregulation. You'll hear a little bit about that. And then multiple cancers. And for those of you who are not familiar with this organization, the International Agency for Research on Cancer, it's based in Europe. It's really the top international agency that deals with cancer. It's been around a long time. Many, many years ago, this is not recent, declared alcohol as a group 1 carcinogen. And just as an example, this is the highest risk group. Okay, you're not talking about modest risk. And other things, just some examples of group 1 carcinogens are asbestos, radiation, and tobacco. So this is telling you how important this is and how we're all too slowly maybe shifting our views on alcohol and what it does to us as individuals and society. So with that, we're not going to, or I'm not going to talk anymore, but going to introduce our first speaker, Dr. Paul Chung. I've known Paul for a long time, and it's my privilege to know somebody like Paul. He's one of the smartest and funniest and most modest individuals that I know. He is currently at the Kaiser Permanente School of Medicine, where he is the chair of Health Systems Science and also the acting director for Health Equity Research. Paul is a pediatrician, but he knows a lot more than just pediatrics. And I've worked with him on many things that are not just related to pediatrics. Before going to Kaiser, Dr. Chung was at UCLA, where he was the chief of general pediatrics and director of the Health Services Research Program at Mattel Children's Hospital. He has many, many honors. I can't even spend time going through all of them. At the national level, for example, he was chair of the Pediatric Policy Council, a federal child health policy consortium. He was also the past president of the Academic Pediatric Association. And his research interests are in redesigning primary care to be more efficient and more effective, not doing the same old thing. How can we do things differently? He's also interested in childhood determinants of adult health. Very important. What you do as a child ends up, affecting you as an adult. Things like child and adolescent health behaviors, juvenile justice, poverty, adversity, and so on. And he does amazing research and has been funded by many, many national and other funding agencies. So with that, Dr. Paul Chung. This is not stuck on the back.
Hi, everybody. Thanks so much for having me. Thank you, Rashawn. Thanks to the center. Thanks for everybody who, oh, can you hear me? Okay. Thanks for everybody who is going to, in advance, tolerate me for the next 50 minutes. So just to be clear, my opinions are my own, and I think I need to say this because everything that will follow is only tangentially related to fact. And I should say this now before both institutions have even more reason to fire me. So the objectives today are to review some of the history of alcohol and alcohol policies leading up to Prohibition. We're going way back, Prohibition, right? And actually, we're going to get back even further. We're actually going to start at the very beginning of human history as it was recorded. So it's going to be a while. And then we're going to talk briefly about alcohol's current role in what's called deaths of despair, which I think probably many of you have heard about, or some of you, but we'll go through it. And then we're just going to see whether there are lessons that we can learn that we might be able to apply to sort of our current lives and our current work. So I was born in 1970. Okay, so I'm a child of the 80s, and I was a young adult in the 1990s. So you already know that I'm really screwed up, right? And but I love this episode, and if you haven't seen it, it's easily available. But more than that, I think this phrase pretty much totally perfectly encapsulates our very ambivalent relationship with alcohol. And so what is the deal with that? What is the deal with our ambivalence? And I think we have to go all the way back to the beginning of human history, right? So traces of beer have been found in archaeological digs from 11,000 BC, I should say BCE, I apologize, BCE in Israel. and traces of wine have been found from 7,000 BCE in China, all over the globe, actually, in archaeological evidence. Intoxication is actually recommended in the Bible, right? We go to Proverbs and it says, "For those that be of heavy hearts, let him drink and forget his poverty and remember his misery no more." Not only do they recommend drinking, they actually understand the reasons why people drink. And in many ancient cultures, alcohol was drunk for a variety of different reasons. And it's actually some of them quite reasonable, right? For medicinal reasons, for religious reasons, and also for sanitary reasons. So they didn't have clean water systems back then. And as you know, alcohol, like rubbing alcohol, but also ethanol has actually some antiseptic properties. And so just ordinary water was regularly laced with alcohol. And diluted beer or wine actually became an everyday drink for all classes and all ages, children, everybody, right? Now, it was diluted, right? So it's not like we were just pouring, fifths of stuff into people's throats. But even, across cultures, you can see written evidence of many, many people complaining because intoxicated people were annoying. And this is sort of written all throughout. It's really kind of astonishing. And eventually, most religions and societies, with some notable exceptions, I think Islam is actually the biggest, most important exception. But most religions and societies ended up deciding to settle on sort of encouraging drinking, but in moderation. You start seeing the words "in moderation" or various versions of "in moderations" from well, centuries and centuries ago. Nevertheless, private and public drunkenness remained common and just generally widely tolerated. It was just sort of a thing, and people kind of accepted it. That is, until the Industrial Revolution in the late 1700s. Okay, basically, capitalism did what religion could not, and actually began a movement directly opposed to the drinking of alcohol. So what about the United States? Alcohol in the 19th century. So first of all, until the early 1800s, hard cider was the drink of choice. Hard cider, why is that? Well, it's actually traced back 200 years earlier, when a Plymouth minister named William Blackstone actually went around and out of the goodness of his heart started distributing apples throughout all the colonies, thinking that they will grow trees. And it seemed like a good idea. It was an apple a day, right? It didn't realize it would end up being in liquefied and fermented form, but still an apple a day. But then in the mid 1800s, beer ended up being imported from Germany. So the German artisans, the master artisans in the mid 1800s ended up painstakingly perfecting a process of creating giant vats of cheap, foul-smelling crap and mass distributing it all over the world and convincing people that this was the beverage of choice for sporting events. And it all started in the mid 1800s, and it took over in the United States with rapidity. But there was something that actually began to come across and push against that. And it was the Second and Third Great Awakenings. Do people know what the Second Great Awakening was? Yeah. It's actually a really, really important part of American history. And what it was sort of Methodist and other Protestant groups began sort of joining together. And it was led primarily by the Methodists, but it rapidly involved other groups and began joining together and sort of advocating jointly for 3 societal reforms. And the history of this was really interesting because what happened was the American Revolution was sort of a profound moment. And it created in these church groups this idea that perhaps societal perfection was possible. Perhaps you could actually create heaven on earth. Perhaps this was actually a sign that there was a rapture and it was coming. And they decided to focus on basically what they considered to be the 3 main societal ills of the time. And they decided to push together for abolition, suffrage, and temperance. So local temperance movements grew out of that all throughout the early 1800s. And then after the Civil War, the former abolitionists, so abolition ended up being one of the the first great big movement of that era. And after that, the abolitionists actually then joined forces and then switched over to take on suffrage and temperance as the sort of new national crusades. And this just multiplied the power of the temperance movement. It was all linked together. And then this movement eventually incorporated other groups. Other people came on, some science began to be developed, professional organizations came on. In 1870, the American Association for the Cure of Inebriety became actually the first national physician association dedicated to treating alcohol addiction. Now, the treatment they recommended at the time was actually horrific. It was terrible. It's basically torture. But it was sort of the first time that professional organizations actually started taking alcohol seriously. But nothing really changed until a dramatic worldwide cataclysm, which was World War I. Okay, World War I changed everything. World War I mean, yes, World War I killed millions of people, but relevant to this talk, World War I utterly destroyed the German beer industry. Okay, just wiped it off the face. And worldwide consumption of beer just plummeted. The German beer factories had basically either been ruined or they'd been repurposed for munitions. And in the US, there were all these patriotic bans on German goods throughout US cities and states. So everywhere, it was incredibly fashionable to be against anything that came from Germany. So this is what happened then. Basically, there was supply disruption in the United States mixed with political anger against where these supplies of alcohol came from and merged with this temperance movement that had been growing all this time, right? And gaining power and gaining steam. So what you saw from the beginning of World War I over the next several years was that local, state, and national prohibition laws were successfully passed. And remember, it wasn't that it came nationally all in one thing. It was first local ordinances, and then state policies and laws, and then finally national prohibition laws, the Volstead Act, that were passed. And then finally in 1920, after the fact, right? Because constitutional amendments are really, really hard, and they really do only occur after the fact in many respects. So in 1920, the 18th Amendment then basically took all of these existing laws and policies and said, this is now the law of the land. And it's important to remember, it actually is really important to remember that what they did was they superseded all of these local laws and state laws and policies, but they did not repeal them. These things were still all on the books. They just were not relevant anymore. Okay, and that comes into play later. So for my generation, all we remember about Prohibition, all we ever knew about Prohibition was that this was the thing that finally allowed Kevin Costner to put Robert De Niro in jail, except that Sean Connery had to die, and so did that little dude. And Andy Garcia became a star and eventually was tapped to take over from Al Pacino as the head of the Corleone crime family. So that's all that we knew. But one interesting thing about this movie, right, The Untouchables, was what did these cops, these members of the Treasury Department, what did these cops do every time they had a good day? They had a drink, right? And what did these cops do every time they had a bad day? They had a drink. They drank all the time, like all through the movie, and it's noticeable, and it was played for laughs, right? It was a funny thing, and maybe it was even true. Maybe the cops did drink as much as the criminals, but the thing about it was that what it did was it impressed upon us, and the same way it's been impressed upon us over and over again, that Prohibition was a failure. It didn't work. How many people here think that Prohibition worked? Oh, we got one. But almost everybody believes that prohibition did not work. It sucked. You know, it caused crime, all these things, right? And the question is, did prohibition actually work? Yes. Yes, it absolutely worked. It worked astonishingly well. So let's talk about this. And by prohibition, I mean that not just the amendment, because it's not so much the amendment, but it's all of that activity that occurred really from the beginning of World War I on. Alcohol consumption was substantially lower than it would have been. Absolutely. Basically, in 1920, you know, when the Prohibition Amendment was finally passed or finally ratified, consumption had actually dropped to 30% of pre-war levels. Okay, 30%. And even by the time of repeal, 13 years later, in 1933, consumption was still only at 60 or 70% of pre-war levels, despite recovering globally everywhere in non-prohibition countries. Other countries did prohibition as well. And what's more, because those prohibition-era state and local laws were never repealed, when prohibition was repealed as an amendment, those local and state laws remained and actually went into full effect. And what we see in terms of alcohol consumption in the United States is that consumption did not return to even pre-war levels until the 1960s. So prohibition kept alcohol consumption down in the United States for 50 years. It was kind of amazing. And during prohibition, daily worker absenteeism dropped from 10% to 3%. The societal effects, and there are many other statistics about this, the societal effects of prohibition were actually really obvious and clear to see. Plus, prohibition created a bootlegging industry, which created speakeasies, which actually led to the proliferation and commercialization of jazz. And jazz is great, but it actually ended up being a major source early in the 20th century for Black-owned businesses and Black artists, Black American artists, to be able to actually earn money in a real and substantive way. It was underground, but it was actually a really interesting and important source of economics for communities. There were negative effects. There absolutely were. Yes, there was a rise in organized crime. Somewhat. We don't actually know how much. We think that actually outside of certain major cities, it wasn't necessarily that much. But this was, you know, but there was some, no doubt. And this was perhaps a more important one, which is that alcohol use disorder during that time became more stigmatized. Basically, it became illegal. And what's more, because it was driven largely by the temperance movement, it became sinful. And those two things together created stigma. And that's a stigma that we're still dealing with today. But those weren't the reasons why prohibition was repealed. So why was prohibition repealed? It was money, for the most part. Okay. The Great Depression. So first, the economy needed a boost. It's hard to imagine, but back then, prior to the Volstead Act, the alcohol industry accounted for 14% of all federal, state, and local tax revenues. That's huge. The healthcare industry today is 18% of the US economy, right? So 14% of federal, state, and local tax revenues. You can imagine the relative size of the alcohol industry and the importance of taxation of alcohol to the US economy. Second, people want an anesthetic. Let him drink and forget his poverty and remember his misery no more. Second was a lack of reliable data that allowed sensationalized news and misinformation to spread. Huh, that sounds familiar, right? Basically, the media exaggerated and romanticized the rise of organized crime. Al Capone, bootlegging, Thunder Road, all of those things became a normal part of our conversation. And it created this enduring myth of prohibition failure, right? And it was a myth. And the public health benefits were never effectively advertised. They were never effectively studied. They were never effectively documented. And they were never effectively advertised. Nobody cared. Nobody talked about this stuff. Right? So how good was prohibition for public health? It's, what were the effects? So we're going to take a little detour. We're going to talk about deaths of despair. Okay, how many of you have heard of the term deaths of despair? Okay, some. All right, well, in the 21st century, we saw something that we had never seen before. Okay, the US saw an unprecedented rise in adult mortality, culminating in the first decline in national life expectancy since World War II. So basically, every developed nation in the world for decades has had steadily declining mortality and steadily increasing life expectancy. And in the 21st century, there was only one developed nation in the world that reversed that trend. Yay, that was us, right? So this was a big, big deal. And everybody was thinking about it. Actually, everybody started thinking about it once Case and Deaton started writing about it. And it was mainly linked to the opioid epidemic. So the opioid epidemic, the importance of the opioid epidemic really can't be overstated. And the epidemic itself has a really interesting history. We talk a lot about, the malfeasance of the pharmaceutical companies and the healthcare industry and blah, 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 and all this stuff. But you can really trace the roots of the opioid epidemic to Chinese trade competition since the 1990s. Okay. That trade competition and the entrance of China into the World Trade Organization, the normalization and the permanent normalization of trade relations with China created a situation where there was a large loss of jobs, of US jobs in certain communities, largely among non-college educated middle-class workers. Okay. And if you think about that term, non-college educated middle class, people who went to high school, who were able to then get good union jobs, manufacturing jobs, industrial jobs, okay? Those were the jobs that were lost. And what it did, many of those jobs are basically located in smaller cities and rural areas. And those communities became gutted. It's not just that people lost jobs. It's that along with the loss of those jobs came the loss of the social infrastructure that supported them. Okay. And that made their lives good beyond just the income that they were earning from the jobs themselves. And those were the communities that became vulnerable to opioid addiction. And opioid addiction then spread in classic epidemic fashion, sort of geographically from those areas. Okay, that's the story, the real underlying story of the opioid epidemic. And it is also interestingly the same story of the election of Donald Trump in 2016. Okay. You can take, and people have done this, and it's really astonishing. You can take a county level map, a county by county map of the United States, and show where the counties were that lost the most jobs from Chinese trade competition, right? And then you can take another county level map, county by county, showing where the biggest rise of the opioid epidemic and the greatest initial mortality from the opioid epidemic was. And you can take another map of the voting districts in the United States and show the largest swing from Obama to Trump between 2012 and 2016. And you can overlay them on top of each other, and they are the exact same map. Okay. This was really a profound change in public health in the United States and more in the social health of the United States. And on top of that, there were also rising deaths from suicide and alcohol. But tracing that story is a lot harder. We don't know. with the degree of certainty that we know about the opioid epidemic, we don't know so much the degree to which those were related. Nevertheless, Case and Deaton sort of bundled all these deaths together, and they called them deaths of despair. So these are deaths of despair. And you can just see it. It's like in your face, right? So if you look at the right side, and you look from about 2000 on, deaths just shooting up. And you see that the vast majority of those deaths are shooting up because of drugs, because of the opioid epidemic. All right, and it's astonishing. We're seeing deaths of despair at levels that we have not seen, we have not recorded in US history before. But going back to prohibition, look at the left side of the graph. And the left side of the graph, you will see the visual evidence of everything that I was just talking about. Alcohol, the second highest peak in deaths of despair happened just prior to the war, just prior to World War I. And most of those were actually related to alcohol and suicide, right? And alcohol-related deaths include essentially things like liver disease, cirrhosis, cancers, other organ damage that's caused by alcohol. And drugs at the time were not really a major player. And then right around 2014 is when the German beer industry cratered, right? And consumption of alcohol fell. And we became really mad, and the temperance movement took over. And what you see is alcohol-related deaths and even suicides dropped, okay, substantially. And during the period of prohibition, yes, you see this sort of slight recovery of deaths from alcohol, but not nearly to the level that we would have expected in a standard post-war recovery, and not nearly the level that we would have seen in other countries after World War I. What you see in the 1930s, if you look at the blue bar, or the blue line, is suicides went way up because we were in the Depression, right? It's just clearly attributable to depression, but suicide went up and alcohol-related deaths did not because of all of these continuing existing state and local laws that kept pushing alcohol consumption down. And in fact, alcohol-related deaths only climbed slowly and did not achieve pre-war levels until the 1970s. Okay. And if you look at all of this, what you see is that except for that period in sort of the 1920s and 1930s, what you see is that for the most part, alcohol-related deaths and suicide go hand in hand. They're in lockstep together, except for a period where we understand the reasons why they would separate. But they are together in a way that drugs and suicide are not together at all. So how good was prohibition for public health? Pretty damn good. It's just really, really hard to deny that prohibition was kind of amazing. It's fair to say that prohibition was the single most important intervention from a public health standpoint in the history of deaths of despair. But let's go back to that link between alcohol and suicide. So alcohol may lower inhibitions of people contemplating suicide. This is just, we know this, right? And in meta-analyses, do people know what meta-analyses are? They're basically just a gathering together of a bunch of individual analyses of similar studies so that you can sort of pool their data and get these giant analyses done. So in meta-analysis, alcohol use is associated with deaths by suicide in a dose-dependent fashion. So the more alcohol you drink, the higher your risk of suicide. And on the other end, in both the US and in Europe, policies limiting alcohol use have been associated with reductions, not just in alcohol use, but in suicidal behavior. And the policies that may be most effective, the policies that have been shown to be potentially effective have included things like minimum age laws, which we have, that's great. Dram shop laws. Do you guys know what dram shop laws are? Dram shop laws basically are laws involving establishments that actually sell the alcohol or provide the alcohol. Things like making a barkeep liable for customer behavior once they leave. So if you own an establishment and you allow somebody to just leave rip roaring drunk and then they go and they get in a car and they kill somebody, dram shop laws allow say that the bar may be held at least partially responsible. Okay. California, by the way, has a law that bans dram shop laws. Okay, so we don't do that in the state. Hours restrictions, no alcohol after the 7th inning stretch, right? basic hours restrictions, and taxes. Taxes are great. Taxes always work, and just in some cases outright bans. These things have all been associated with reductions in suicidal behavior. And although opioid use is also associated with suicide, the vast majority of deaths from opioid use are unintentional. Opioids are just different. It's a different ballgame. Fentanyl is different, okay? Fentanyls and synthetics mixed with meth. These are cocktails that in many respects alcohol can't touch. They just operate differently. By time and space, variations in suicide rates track more closely with alcohol than with opioid use. Okay, let's get really current. Okay, so what did COVID do to alcohol use? So it did everything that you would have expected it would have done. Okay, so social drinkers drank less. Okay, if basically fewer people overall drank in the past 30 days, and fewer young adults binge drank. Okay, so that's great. Nice. COVID again, horrible, but one nice unintended side effect. But in 2020, so solitary drinkers actually drink more. Okay, so what we saw is sort of this bifurcation in drinking patterns. More middle-aged adults drank daily. Young adults less middle-aged adults, absolutely. And those who did drank more often, they drank more when alone or at home, and they drank more to relieve stress and boredom. Basically, what COVID did was it made things worse for those who are already at high risk for alcohol-related deaths. Okay, just took that high-risk population and they made it more high risk. And therefore, in 2020 and 2021, alcohol-related deaths rose 27% among men and 29% among women. Not surprising. But it's not all bad news. It really isn't. There's lots of things that make us think potentially otherwise. In the Monitoring of the Future survey, self-reported 30-day alcohol use in grades 8, 10, and 12 continues to decline straight through the pandemic, all the way through. It's now 14% in 2023 versus 18% just before the pandemic versus 40% back in 1991. And it's not just alcohol, it's substances across the board. Cigarettes, although the cigarettes is a little bit misleading because there was also vaping. So 2.1% sounds kind of amazing, but it's less amazing in the context of vaping. But even vaping has been going down, broadly speaking, over the last 4 years, 5 years. And illicit drugs overall have been going. This is despite the opioid epidemic, right? We're still seeing overall decreases in the use of drugs. And because when you start so strongly predicts lifelong use, this bodes well for the future, right? Now, there are pockets, there are subgroups, there are all kinds of folks who remain at really, really high risk. And for some groups, risk may even be increasing. But overall, if we're talking broadly about the United States, these are good data. So what lessons can we learn from cigarettes? I think some of the most important factors in reducing cigarette use are not entirely clear, but all of these things likely helped. So first, there was the science, right? The science helped. There were these seminal studies in the 50s that basically established the scientific link, mainly through epidemiologic research, but that's been confirmed over and over again, culminating in the US Surgeon General report in 1964, which was really a sort of a milestone moment in smoking in the US. However, many doctors and scientists continued to resist this until the 1980s. Okay, we were the problem, right? Or part of the problem. Marketing. There was a series of sort of marketing restrictions and initiatives. Cigarette package warning labels, banning of cigarette advertising on television and radio. That was big. And then in 1998, there was the Tobacco Master Settlement Agreement, which banned youth targeting of tobacco advertising. Taxes. Taxes are good. By 1969, all states had implemented cigarette taxes, and CHIP legislation added actually more than $1 a pack federal cigarette tax, and penalties. The MSA was the largest civil settlement in US history at the time. It was over $200 billion of money that got transferred to states, okay, for tobacco prevention activities and other things that states needed. And there's been a lot of debate about how states actually use that money, right? But still, it was a compensation payment. What lessons can we learn from prohibition? From all that stuff that we've just been spent this whole time talking about? First is that economic and emotional security matter. Like, there's all this stuff that we talk about the substance itself, about the use, but so much of that is predicated on the underlying conditions. The best way to help him forget his poverty and remember his misery no more is just to help him be less poor and less miserable in the first place, right? That is actually fundamental. And media and misinformation also matter a lot. Not just advertising, but also just this cultural glamorization and normalization of alcohol. We normalize alcohol. I don't know that we glamorize it that much anymore. I think that has actually changed a little bit. But we normalize it for sure. And we need to stop claiming that alcohol is good for you. You know, for decades, epidemiological studies have shown this association. Whoa, sorry. Spam likely. For decades, epidemiological studies have shown this association between low to moderate drinking and better cardiovascular health. Like, we see this over and over and over again, right? It's there. You can't avoid it. And because of that, many doctors and media outlets still today routinely recommend low to moderate drinking all the time. It's good for you. Have a little bit of wine. Everything is good, right? But when we really dig into the data, what we see is that this association might actually be false, misleading. That it turns out that the people who are the ones who are going to say, yes, I drink in low to moderate fashion, and I successfully sustain that level, those people are probably in heart healthier situations to begin with. That there's a selection bias going on here that we can't get rid of in our analyses. But we can sort of get rid of them in our analyses if we look hard enough. So I want you to first just look. I really like this study. This came out in JAM a couple of years ago. And it takes the same data set and basically applies 3 separate analyses to them. So I want you to take a look at the top 2 graphs, the ones with the yellow and the blue dots, okay? First, look at the blue. And what you see is what we call the classic J-shaped association. And what you see as alcohol use increases of the bottom, what you see is that both hypertension and coronary artery disease actually drop, right? You see it go below the line for that low to moderate range, and before it starts rising up again. That's that classic epidemiological association that we see over and over and over again. But I was talking about the fact that it might be false. That is, there might be these confounders, things that actually confound the association, that make it look real when it's not, like other lifestyle choices, other socioeconomic status indicators, other things like that. So when you try to take whatever data you can find, what we call measured confounders, and you put them back and you put them into the analysis, what you then see is the yellow dots. And those yellow dots show that little dip is a lot shallower, still there, but shallower. It's kind of gone away a little bit. And the thing about these regression analyses that we do is that there are measured confounders, but then there are also what we call unmeasured confounders. There's all the stuff that could also be making this effect, but we just don't have any data on them. We can't stick them into the analysis, right? So we miss them. There are ways to also try to deal with not just measured confounders, but measured and unmeasured confounders. And one of these ways is this thing called instrumental variable analysis, which you don't have to get into. But the thing about this analysis is now we look to the bottom. When you do an instrumental variable analysis, what you show is that that little dip goes away completely. It's completely gone. All right. Now, instrumental analysis is problematic. It has all kinds of issues. We can't say all of this stuff with a lot of confidence. But what we can say is that the evidence is trending towards this idea that no, there's no hard benefit. That low levels of drinking may not be that damaging, right? But we can getting rid of this idea that we can tell people, oh, you should drink. You should have a little bit because it's good for your heart. Right. So when I think about all this stuff, the thing that comes to mind most is that prohibition was just not one thing. Okay. Like, it was useful for me personally just to go through this whole history again, because it just reminded me that prohibition was not this one thing. It was slow building. It was community driven. It was cultural. The temperance movement didn't come from some government organization that said we need to do such and blah, blah, blah. The temperance movement was purely grassroots. It started in local churches. It spread outward from there. It involved organizations. It involved alliances. And it took 100 years of this movement. And it became policy, not through this prohibition amendment. It became policy through the accumulation of local ordinances and then state laws before the Volstead Act and the 18th Amendment ever happened. And those ordinances and laws varied, right? It was not a one-size-fits-all policy. This is the heart. If there is one maxim for implementation science, it is this. It is global standardization and local customization. That customization is really, really key. And in many ways, it was similar to the gradual 20th century sort of multi-pronged approach with respect to cigarettes. What I'm trying to say is that science and public health, I doubt, are going to be the real vehicles that are going to drive alcohol use reduction. Okay, it's going to come from everybody. But science and public health can justify, it can support, it can help sustain efforts by individuals and communities and governments. And advocacy is a long, slow game of hope and attrition. Martin Luther King talked about the fierce urgency of now, right? And that is really important and really seductive. It is a siren song, but it's also double-edged. It's a double-edged sword, because when we talk about the fierce urgency of now, what we're really talking about is the urgency for action. But we have to divorce that from the idea of the urgency of results, of outcomes. If we bank all of that urgency on outcomes, we are going to be disillusioned and disappointed. And what we're really talking about is, you and I, we're not going to be around when things really get noticeably, visibly better, right? And what we need to do in many cases is just to understand that, to accept that, and to wake up every day and still decide to take a step forward. And then to wake up the next day and take another step forward. And to call on ourselves and to call on our friends and for them to call on their friends and to link arms and to take a step forward. And maybe we're not going to get there, but maybe our kids will. And that ultimately is the American dream. That has always been the actual exact definition of the American dream. It's not about It's not about heaven on earth. It's not about rapture in our lifetimes. It's not about any kind of quick gratification. What it is, it's about this little idea that maybe our kids can live in a better world than we do. And that is how winning is done. Thank you. Oh, okay, question.
Have questions? There we go.
I don't know if I need a microphone, but so curious as you're talking
Give her a
about,
microphone.
in terms of talking about the local policies that were on the books leading up to prohibition, what do you see in today's landscape in terms of the local level, some of the shifts in that direction that address alcohol consumption, whether amongst youth and communities? Kind of where
Yeah.
are you seeing some movement there?
I think that's a really good question. And I think it's not likely that we're going to be actually instituting sort of dry laws or anything like that. I think that's just, it's not in the cards right now. I think the types of interventions we're talking about have more to do with, maybe in states other than California, maybe even within California, some sort of liability laws. We're starting to see actually things like parental liability and other sort of business liability for a whole assortment of things, right? And that seems to be a movement that actually is gaining steam, not just in alcohol, but really across the board. So that might be an avenue. It's hard to know where we're going to go with taxation, and I can't make any predictions about that. But I would say that's probably the next frontier that I see is those sort of liability issues.
Hi, I was just wondering, is there data that shows that dram shop laws or like regional laws that restrict alcohol are working?
Yeah, so there are in places that allow dram shop laws, there's evidence that suggests that they're effective. And dram shop laws are done primarily at either the state or the local level. Again, in California, we're kind of, our hands are tied a little bit, and it would require really state level legislation to change that. But that's a real battleground, and it's not just in the U.S., but it's sort of in other countries as well. It's a real area that people are looking into. So.
Good morning. I just really appreciate the EPO history and the background, and for you, Dr. Chung, being a pediatrician, because you see the impact of FASD, fetal alcohol syndrome, in children, and you see them growing up into adults that are in the system or justice involved, and that's something that we don't talk about globally, locally, and statewide. And so I'm just wondering your thoughts about that in your work and prevention and intervention and education, because I see that in my work. It's not talked about, it's slightly talked about and addressed, but FASD is a huge issue in our county and our country.
Thank you. One of the things that I think one of the things that's kind of messed up about our primary care and sort of healthcare system with respect to this is the fragmentation of care based on age. So what we see a lot is that there are issues, and this has a specific impact on maternal and child health. If you really take maternal and child health seriously, what you're really thinking about is talking about the care of pregnant people before they even become pregnant, right? Preconceptional health, which is, for most people, what we're talking about with young adulthood. Okay, preconceptional health in young adulthood to post-conceptional health, to prenatal health, to perinatal health, all the way then going seamlessly into pediatrics. it's only that type of approach that actually I think is, and not just on a healthcare system standpoint, but actually on a public health system standpoint, that is going to actually make a dent on fetal alcohol syndrome, on FASD. Because without that sort of really integrated, holistic approach to the maternal and child health system, you can't attack it individually, right? And I think our main problem is that we're trying to attack it individually, and that requires basically a sort of a restructuring of how we think and how we operate with respect to maternal child health. So I think that's a great point and question.
Okay, yeah, little question. So it's really interesting, right? Because definitely I have made some take a look to the whole prohibition situation. And I'm not going to say I'm a staunch prohibition advocate. Okay, I'm not going to necessarily say that, right? But even if you look at the room, right? And you see that a lot of us conceive prohibition just from the negative aspects of it, right? I'm also one of the organizers of the California Society of Addiction Medicine Conference. And I bet if you go to the 600 people that are to attend that conference, at least 98% will think the same as we thought in this room. How can we approach this topic to have a more balanced and nuanced conversation about good aspects of the provision that had in things that we conceive that maybe were not appropriate?
Well, I think I think part of it is that we can't have these conversations yet because we have simply erased the history, right? I think before we can even talk about this thing, we actually have to raise awareness of the actual history of prohibition and what happened, and that, you know, that's a different type of campaign that needs to happen before we even start having these sorts of genuine substantive conversations about whether it's good or bad. So that's step one. I also am like, you know, part of me is just like, sure, it's nice to think about prohibition, but I also kind of want to do stuff now. And how much effort should we spend talking about prohibition when there are sort of really practical issues of today and tomorrow that we can try to address? And I'm not sure what the answer is. I mean, I did it for this talk because I got the sense that most people think that prohibition is a failure, and I would like to sort of push back against that a bit. But I also think there's so much work on the ground that has to be done for today and tomorrow. So it's a great question, and I don't know the answer, but thanks for asking.
Good morning. I appreciated your review of prohibition. And
hi.
it started to make me think about how, at least in the state of California, most Indian reservations don't allow alcohol. But then I also start to think about the high numbers of, consumption rates for those American Indian reservations. So I was just trying to get a sense of, I know it's kind of a wicked problem, but what factors, I guess, kind of lead to that, or like attributing to the outcome that we're seeing?
So locality matters, right? Locality matters and borders matter. I realize borders are a very touchy subject, and they should be, but borders actually, the free flow of commodities and people in and out of spaces makes it very, very difficult to exert local control. Okay, so that's a huge problem. That's why during prohibition and afterwards, local and state governments really, and federal governments really needed to actually invest a fair amount of resources on preventing transportation of alcohol across state lines, transportation of all of these things. And so there's this just investment aspect to it, that if you're going to have essentially free passage of goods and services and people, that you're going to have to put in upfront. And that's one of the reasons why, I mean, I don't really ever expect us to get back to a prohibition era thing, in part because our economy is so much faster now, right? It's not about bootleggers, driving across state lines on Thunder Road. It's just about this instant transfer of goods, services, and people. And that's just a much bigger kind of thing to try to tackle. So it's a great point.
Hi. You discussed some parallels between tobacco and alcohol, especially, how it's been glamorized, et cetera. What are some reasons that you see as tobacco haven't been addressed by litigation and sought after for reparations? And what are some lessons that we could learn from that, maybe to bring into the future for alcohol?
That's great. So some of my early research, my earliest research as a fellow and as an early faculty member was I used a statistical analysis to show that tobacco companies were violating the master settlement agreement with respect to youth targeting. And then I took that same analysis, and that was used by state attorneys general in some of their litigation and stuff. And then I later used the same technique to look at Nielsen advertising data to show that alcohol advertisers were targeting kids pretty much worse. And the thing about it is that alcohol advertising targeting kids is totally legal, right? It's totally fine. The only thing that our article was able to do was to try to shame them a little bit, right? And so I think the things have to go hand in hand, right? You're not going to get massive civil litigation until there are at least some laws on the books that do something with respect to alcohol, until there's enough of a popular movement to actually make it likely that judgments will be set in favor of, or settlements will be possible with respect to this. So that's a key difference, I think, between alcohol and tobacco. I think tobacco, before the Master Settlement Agreement, which is 1998, which is really late in the game, right? Before the Master Settlement Agreement, there was a long history of genuine concern about advertising with respect to tobacco, and then also with the idea of reparations, basically, of compensation payments. So,
hi.
So this will be the last question, but thank you.
Hi. So I know you talked a little bit about how a lot of reducing alcohol consumption can't be done without an increase in social services as well, right? Like we can't talk about alcohol consumption without a sort of context of why people do consume alcohol. So I was curious to know if you have any type of examples of social services that should be set in place to help in tandem reduce alcohol consumption, or have it rally as a way to target that.
Yeah, I think that there is no doubt that that standard safety net solutions with regard to poverty are really effective, and that actually we underplay that, right? We talk a lot about, well, this is a problem, we're going to develop a new program for it. This is a problem, we're going to develop a new program for it. We'll attach a service to this, we'll attach a service to that. There are really amazing anti-poverty cash equivalent, cash transfer programs that exist in the United States that we simply underfund. If I had to pick one intervention that to hit that side of it, that's actually the first thing I would do. I would really try to make sure that our safety net is an actual safety net and not just a hole, right? And let's fix that first. I think if we do that, that's sort of the biggest bang for a buck overall. But on top of that, then, yeah, I think we actually need to investigate better about sort of what the individual impact of particular social programs are for folks who are struggling. But there's a broad mass of programs that have both individually and collectively been shown to be really effective at improving not just economic outcomes for families, but health in families. And we should implement them. We don't need more science on those. It's really just about the politics of it. Just Build Back Better, I have to say. Build Back Better actually had provisions in it for child and family sort of development, welfare, and whose effect would have been profound. Okay, Build Back Better failed by the vote of a single senator. right? It passed the House. It failed by a single senator who held it up. And it could have been actually fairly transformational.
Thank you.
Thank you.
Thank you, Sue. That was a wonderful talk and maybe a little different than what you might have expected, but really very important for us to kind of think more deeply about these issues and not only be fixated on numbers and so on. So thank you very much. And as usual, wonderful talk. Dr. Beth Glenn, who is a professor in the School of Public Health and also one of our associate directors at the center, will introduce and moderate our next session.
Thank you. So I have the pleasure of introducing our next speaker, Dr. Julio Mesa. Dr. Mesa is an addiction and family medicine physician at the David Geffen School of Medicine at UCLA and a psychiatry and primary care certified physician at UC Irvine. So Dr. Mesa was born and raised in El Salvador, where he studied medicine before coming to the US to complete his family medicine residency. He's worked in a lot of different communities here in Los Angeles, and he really enjoys serving patients from all kinds of backgrounds with really his heart in equity. So in addition to his faculty positions, he is also the program director for addiction medicine, for the Addiction Medicine Fellowship and part of the Liver Transplant Committee at UCLA. So today is going to talk to us about alcohol use disorder as well as his work in family medicine. So thank you very much.
There we go. Okay. Good morning, everyone. And thank you very much for inviting me and have this opportunity. I'll speak slightly in regards to definitely alcohol use disorder, impact on health, and some of the things that we as primary care providers can do, right? We tend to have all this bulk of work that we deal with, right? And definitely a lot of meaningful impact occurs in primary care, not necessarily some occasions to think as we have to detect the problem, make the diagnosis, and establish treatment until completion, and we have everything resolved, right? Some occasions, the eagerness and the desire to help our patients makes us fall in that little trap, okay, in which that's why there are other individuals that might be able to help us, okay, when we are in moments of need, okay? Definitely I don't have any disclosures, okay? And just a little landscape of the latest stats that I was able to find from 2023, okay? So pretty much about 14.8 million people are actually diagnosed with alcohol use disorder as of this moment. That's about 4% of the US population. Now, these are people who are diagnosed based on DSM-5 criteria, okay? Lots of these people, they don't make it to a psychiatrist, an addictionologist, or a primary care doctor who is using DSM-5 criteria. So we might still counting maybe, who knows, I'm guessing, right? Maybe about 50, 60% of the total amount of people who actually endure this condition, okay? Maybe I'm lowballing that, I'm not certain, okay? But just this number, it tells us a lot on the big situation we're dealing with. And I know that in my field, something that has made waves for so many years already, right, is the opioid epidemic, and definitely we should speak about that, right? But let's not forget that until now, alcohol still continues to be the most common cause of drug-related death in the US, okay? Hands down, even more than tobacco at this point with the decrease in tobacco consumption. So some occasions we tend to think that people like myself, we just deal about opioids. No, alcohol is big, okay? Another thing that we can see over there, right, is what the effect of alcohol, of COVID, as stated on the slide, okay, more than anything, I will say regulations that we deemed to be appropriate for that moment in time in our history, right, that were established, how they affected alcohol consumption. And as we can see, drinking increased in about 60.14% of the population. It decreased only on 30%. So more than half of the individuals who were drinking, as it was really well mentioned in the talk before me, right? Especially those drinking in solitude, okay, not the social drinker necessarily, right? those drinking in solitude, the ones that we call ourselves, I'm a functional alcoholic, all right? We have heard that term as well, right? Definitely we notice a spike on alcohol consumption. And about 27% no change, definitely. Now, the causes of alcohol-related deaths, and I can give you hard data from these statistics, but also I can tell you empiric data of what we see on service. And I see some hepatologists that I know here, specifically from UCLA, and they won't let me lie, okay? Before 2020, the majority of patients in the, at least in the UCLA liver transplant service, they were not related to alcohol. We had more situations of hepatitis C, carcinomatosis, cholangiocarcinomas, 2020, and things that we established at that moment. Okay, now pretty much our service, about 60% of our transplants or even more, they're alcohol-related cirrhosis. So definitely we have seen a stark change in that regard, okay? So definitely something that is impacting our lives, impacting the lives of our patients more and more. Now, how did the sales go during the stay-at-home orders, right? Just in really crude numbers, okay, about alcohol sales pretty much increased by 35% ever since the stay-at-home orders were instituted. If we see more organically, okay, we see two lines on the first graph right there. The orange line tells us that there is a decrease of alcohol consumption, but specifically on places of dining and restaurants. Why? They were closed. So we couldn't go there, right? That's it. But the blue line, that is people going to supermarkets, liquor stores, okay, how did that one go? Increased quite a bit, okay? 35% on alcohol sales were increased, and this is only measuring specifically to the number of alcohol sales themselves, not the amount, okay? When you measure amount, the amount went in the billions of gallons of alcohol sold in the United States ever since 2020. Needless to say, alcohol-related deaths, as I mentioned before, right? We're all concerned about opioids. We have listened about the statistics, right? But if we look at the graphic, right? Pretty much alcohol matches just in intoxications and specifically liver diseases, alcohol-related death, they're really close to the number that opioids throw as well, okay? This is not including accidents, not including suicide, and all those other factors. So, what does alcohol do to our system? It does a lot of things, okay? Definitely it's a carcinogen, as we all of us know, right? But the first thing is going to be affect our central nervous system, right? Whether we like it or not. Often my patients with alcohol use disorder will tell me, well, Dr. Mesa, I think I can't stop because I'm just a bad person, right? It's a bad habit that I have to kick out, okay? I face myself often with going over a little bit of physiology and neurobiology with them so they can understand that the reason for which some occasions, because believe me, even when I treat patients with alcohol use disorder, they're surprised, right? Especially when we have those initial days of sobriety. Well, Dr. Mesa, I came to see you because I'm drinking too much. Now I'm on an antidepressant, I'm on this thing called gabapentin, I'm on trazodone, right? Why did I end up with 3 or 4 more medications than what I was taking before, right? Fair question. All of those are powerful medications. I'll be honest with you, I have never taken gabapentin. I bet if you give me 100 milligrams of gabapentin, I'm going to fall asleep immediately, okay? And that is for sure, okay? Needless to say, if I'm taking trazodone and hydroxyzine for my PRN anxiety, right? But the situation is this, right? The reason for which I go into a bit of neurobiology with my patients is because it makes sense based on what I'm needing to counteract. Alcohol is not just about having neurobiologically, it's going to actually enhance the activity of GABA. Over time, what's going to happen? Our brain has to live in a nice balance. So our brain is going to start to overproduce glutamate. When we remove alcohol and someone goes through withdrawal, whether it's well managed or not, right? Now we're going to have that excess glutamate overpowering GABA. So what's going to happen? People can have seizures. Heart rate is going to increase because it's going to create actually a catecholaminergic storm. So they're not going to feel comfortable. Those are the initial 7 days, right, in which people are shaky, heart rate is really high, blood pressure goes pretty elevated, right? Over those next 7 days, the glutamate amount will decrease, but not to baseline. It takes anything from 8 weeks all the way up to 48 weeks for the glutamate to go back to baseline. It's impossible to predict whose glutamate is going to get better, faster, and in really good fashion. So although, as I explained to my patients these facts, and I show with little drawings that I have, not just talking, it doesn't make any sense, right? So as I explained to them, my situation of giving gabapentin, X, Y, or Z medication for symptoms is only and only to temporize and counteract the effects that glutamate is having. How do I know when to stop it? Who knows? When do you think is a good idea to start to reduce those medications? Who can throw me a wild guess? When the patient starts to tell me, look, Dr. Mesa, I'm taking that gabapentin thing and now it's making me drowsy. You got it, okay? That glutamate is reducing closer to baseline. As the glutamate reduces, medications that before wouldn't touch them, because believe me, I bet all of you have seen this patient, right? The patient in which you're giving 300, I'm still anxious. 600, still anxious. 900, okay, let's add propranolol, right? Let's add this and let's add that, right? You do not see any effect. You're fighting a really powerful neurotransmitter that has actions over adrenaline and noradrenaline and dopamine in our brain. So when the patient starts to tell me, look, Dr. Mesa, now this thing is making me drowsy, I know we're in the right track. And usually I tell them, be happy, we're on the right path in this case. What else is alcohol going to do? Definitely, as mentioned before, and I'm going to go into many details on it, it's going to cause stroke. We're going to see a lot of changes as well in some biomarkers, right? We're going to see that GGT can be elevated, AST, ALT, needless to say, MCV as well is going to be elevated on our patient population, right? Bone marrow is highly affected by alcohol. We're going to see thrombocytopenia. We can see anemia as well. We can see leukopenia. So alcohol can actually be a pancytopenic for some of our patient population. And all these depends on the length of consumption and also the dose itself. But one of the big things that I'm really passionate about is alcohol and its effect on liver disease. I'm not diminishing how much affects other organ systems, okay? But this is what I deal with in a daily basis, okay? Added to that, let me tell you a little story, right? The reason for which I'm so passionate about this thing is specifically because my grandfather actually, he died of a variceal bleed when I was 6, okay? He used to be someone who had really heavy consumption of alcohol in El Salvador. Even till today, we don't have really good technological schemes to treat our patients, right? So needless to say, back in those days, right, when I was a child, right? So definitely something that kind of has led me to always be engaged with patients with alcohol use disorder to try to explain them as best as I can, okay, in a non-judgmental fashion, how alcohol can be actually in detriment of their health. And the reason for which I want to show this slide is because, for example, as we can see, the stages on liver damage with alcohol, specifically after being normal, right, our liver is going to change to be an steatotic liver, okay? And if something I can hone in today in this talk, non-alcoholic fatty liver disease is a diagnosis of exclusion, okay? Please remember that, okay? Non-alcoholic fatty liver disease is a diagnosis that we as primary care doctors should make, or if we deem that we do not have the tools in our system to do so, okay, to get use from, get assistance from our hepatologists, gastroenterologists, whoever, okay? Because you will be amazed how many times I'm doing that interview, okay, in which the life of a patient is on the line, in which is like, so when did you know about your liver disease when we're planning to perform a transplant? And so many times it's going to be this answer. Well, my primary doctor told me a little bit about it, but he told me it was fatty liver, so to stop eating fats. And I'm like, okay, can I blame the patient for stop eating fats and not engaging into decreasing alcohol consumption? Definitely I can, right? I don't have room to that, okay? That's why definitely we have that there are so many causes of steatosis, okay? Hemochromatosis can give steatosis as well. Wilson's disease can do it too. Hypertriglyceridemia. So all these conditions, autoimmune diseases as well, they will start at steatosis initially until the major changes occur, okay? So in my case, and that's why to our residents and fellows, I was telling them, when we have an AST, ALT elevation, we'll do all the workup necessary and until everything comes back negative. In our case, it's kind of easy. Most of our patients, they're looking our services because of alcohol, but still we have to do our due diligences. And then we can call that non-alcoholic fatty liver disease, okay? So we go through the workup of all these markers. On occasion, we call rheumatology or hepatology to see if we need any guidance specifically on how to diagnose it, okay? But definitely it's important to remember that NAFLD is a diagnosis of exclusion once we definitely exhausted all our resources to diagnose everything else. Now, how do I know about the intake of my patient? Okay, simple. Ask. It's just as simple as that, okay? I know that a lot of us, we have heard talks about stigma and all that thing, okay? I think at this point, we're kind of stigmatizing a stigma, honestly, and so many times that I have heard that talk, okay? Because at this point, you're okay if you do, okay if you don't as well, right? Because you're like, okay, if I ask, is this patient going to feel offended if I ask about their alcohol consumption, right? So I might as well don't do it, okay? Because let's not forget, a stigma is something that implies that we have a bad characteristic attached to a patient. When I approach a patient, whether it's in my primary care sessions or in my addiction medicine sessions, I'm not doing it because of that, right? Same thing is going to happen with their diet. If I normalize the way in which I ask questions, just as I ask about their diet, how their day is going, we're going to definitely eliminate the stigma in that fashion, more than walking on eggshells on how should I ask this question, right? So in the same way in which I go, so tell me, how many sodas do you drink? Well, Dr. Mesa, maybe 2 or 3 a week, right? Okay, cool, okay. How many times do you go to the bar? How many times do you have wine? How many times do you have any type of alcohol? Not too often, maybe once a month. Okay, on those days when you drink, okay, how many of those do you usually have? Maybe 2 or 3. And then I go back to the diet question. I like to put it with diet so people feel like everything, we're speaking of the same exact topic. And then I go, okay, now can you tell me, do you, especially because I see a lot of our patients from Hispanic heritage, definitely I ask them, right? So how many tacos do you tend to eat? Well, like what 3 tacos with 1 or 2 tortillas? With 2 tortillas. Do you ask for chata or water with it? Well, and the conversation flows more nicely, right? So no one feels like I'm just singling out the alcohol. I put it with the meal. So in order for that, patients feel that definitely we're engaging into a full-blown conversation of their diet without necessarily just putting that stress on alcohol, okay? Now, as we definitely know now, right? No alcohol pretty much is good for our lives, okay? But definitely the CDC has some specific guidelines of what a, like patients call it, normal alcohol intake should be, right? Which we have the numbers depicted right there, okay? And to be honest, this is a question that I get frequently, right? Because a lot of patients, when they come to see me, they're like, well, this guy likely demonizes alcohol, right? He might not even have touched alcohol in his life, okay? Neither of those are true, okay? I have touched alcohol in my life, okay? I had a drink, okay? And definitely I don't demonize alcohol either, okay? But in the same token, as I tell patients, right? Because when they start to ask me those questions, what is a normal drink or what is a normal amount of alcohol I can take, okay? So I explain, look, based on CDC guidelines, this is what is recommended, okay? Based on your liver testing, this is my current recommendation, okay? If your liver testing changes, your liver is the only one who tells us the truth. At that moment, we abort any mission that we may have, okay? It doesn't matter what I say, doesn't matter what the CDC say, because no one is going to take your life at that moment, okay? So definitely, we have to continue to work together in order to achieve goals that can be in accordance to what you want, but also if you're here, it's because you want to be healthy. That's what I'm here to help you with. Definitely, there are multiple validated screening tools in primary care. Pretty much, we have all these ones in our EMRs, okay? You might ask me, how often do I use them? Pretty much it's never, okay? I'll be bluntly honest to you, okay? Because I just don't have time, and I bet you face a similar situation in your clinic, okay? Because at the end of the day, right, if my patient is telling me, look, Dr. Mesa, after we have that nice conversation about the tacos or fajitas or whatever they eat, right? And they tell me, yeah, you know, on my birthday, definitely got into an issue with my wife because I became too belligerent because I was too inebriated, right? Just right there, he met 2 criteria for alcohol use disorder on the DSM-5, right? He meets criteria for alcohol use disorder, and we'll talk about it in that regard, in that fashion, okay? But definitely, if you are going to use one, I would recommend the most simple one, the NIAAA single screening tool. Is simple, to the point. It's just in these past 12 months, did you have a day in which you have more than 4 drinks at once for women or more than 5 for men? And you're okay. If someone had that, definitely they meet at least one criteria for alcohol use disorder. That's it, okay? And then you can avoid the topic in the way in which you find it better suited. Now we have blood work as well. We have urine work as well that we can send, okay? And I was having a talk with a colleague of internal medicine recently, and he told me, well, but when you send these labs, you increase the stigma around alcohol. Not if it changes my management, right? Like, for example, if I tell you, look, all of you, I never eat candy, but if I'm over 35 with a history, personal history or family history of diabetes, are you going to say like, it's going to be stigmatizing to do a hemoglobin A1C on this guy? No one thinks like that, right? So definitely it's going to change management depending on the findings. So similar situation is with some of these markers. If we have sound decision-making and we can explain to patients why we are doing it, it is okay it's not stigmatizing. For example, the one most commonly we use is called phosphatidyl ethanol, which is right here. Why do we like it? It has a fair sensitivity, but a really good specificity, 96%, okay? It's going to tell us the potential degree of alcohol consumption in the past 28 days. So it's kind of like the fructosamine for alcohol. It is good, okay? And I put it like that for my patients. I tell them, well, you know, you mentioned that you had this dinner party in which you had problems with your wife because you were too inebriate, okay? Let's see if this lab matches what you're telling us, okay? And we can establish a potential plan, okay? Maybe the phosphatidyl ethanol will reveal that the alcohol consumption is higher than what the patient had described. Will that change my management? Yes, it will, okay? So definitely I'm going to be able to use this diagnostic tool in order to help me to provide better care to my patient, okay? Then also we have some other markers which are pretty fair, okay? Acetylcholine and ethyl sulfate. The only caveat is the duration in which they stay on the system, okay? So that's why I prefer phosphatidyl ethanol, because definitely allows me to engage in a better conversation. And because most of my patients, they have had a hemoglobin A1C at some point in their life, they understand the concept. So that's the beautiful thing. It matches the concept of hemoglobin A1C. And some of them, they just love to go from, let's say a phosphatidyl ethanol of 75, just to give a number, which is mild consumption, okay? They love to see that thing going to 0 and staying at 0, okay? So some people, they just do it as a habitual type of thing, and it is okay. So what does helping means from the standpoint of primary care? We have to ask questions. Those questions that some other one may not want to ask or might feel concerned about asking, okay? That's why we're here, to provide a non-judgmental space to our patients. We're here to provide guidance as well. We're here to investigate, but don't judge, okay? We're just going to provide data to patients so they can have information. At the end of the day, right, the word doctor, that's what it means. It just means teacher. We're just here to teach. As I tell patients, I'll give you the recommendations. You decide how you want to take them. And if you want my recommendations and you decide to take them, I can help you on the pathway to pursue them, okay? Ask about patient goals, okay? Some patients, they're pretty clear to say, like, look, I love drinking and I want to drink until I die. And I respect that, okay? I just tell them, look, these complications may occur. We're just going to monitor for Y, X, or Z, and we'll go from there, okay? And if you're still satisfied with that goal, it's your decision, okay? And another thing, alcohol use disorder is a chronic condition, no different than diabetes and hypertension, okay? That's why I don't kick out people of my clinic if they re-engage into drinking alcohol again, because that's why I'm there to help, right? Because if not, I will have to actually dismiss every single patient who on Christmas has a hemoglobin A1C or that blood sugar level to go to 500. I will have to do exactly the same thing to be as just as possible, okay? Thank you very much for the time today.
Start us off. Oh, here we have a question. Over here, yeah, the green, yeah. She's coming, thank you.
Yes, thank you. I work with cancer patients, but sometimes in the patient navigation, we come across people who have survived cancer, and I don't think that they are still willing to reduce their alcohol consumption. So, any suggestions?
Yeah, exactly. And at that point, it will be to explore the reason why. Oh, my apologies. Yeah, it will be to explore the reason why, right? If they're satisfied with that, you know, as I mentioned before, right? I'm not to judge anyone. You will be amazed how many times some patients, they may come to my clinic still drinking quite heavily, okay? And I may have 5, 6 visits with them, but they're showing up, they're coming. So they know that there is something good on what I'm telling them. They're just not in that moment. They're not ready to make the change. So pretty much every single conversation is trying to find out why what is alcohol doing for them that they find so beneficial despite the negative consequences, right? If they can give me a decent list, and usually I just ask for 3 items, okay? Which ones are the 3 things that you still enjoy about alcohol, right? Boom, 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 okay? Can you tell me 3 things that you may not enjoy about alcohol, right? And as you notice over time, right? And as we do more and more encounters, right? Initially the list is, nah, I love it. I find nothing negative, right? Then at some point it's like, well, now I have to come and see you. I'm like, okay, cool, that's fine, you know, kind of like a pleasant guy sometimes, okay? But then definitely the list starts to become a little bit longer and longer, okay? So that's usually a good strategy, just to have them list you something, okay? And you're going to be able to see that change, because if always is the conversation about, well, are you ready to quit today? Are you going to, what do you think about going to AA? Do you want to go to Smart Recovery? Do you want to see Dr. Mesa for medications, right? More likely the answer will continue to be no, okay? So it's always to explore and throw the ball back to them, okay? Tell me what's positive about alcohol at this moment of your life that you survived cancer, okay? And what are the drawbacks that you see? Well, now my wife is mad at me, you know, in situations like that. So definitely things start to come.
Yeah,
as
because
time
it's
goes.
a combination with the psychological aspect and emotional aspect, yeah.
It is pretty big. You will be amazed how many times, and as I was mentioning, right? Some occasions patients may come to see me for alcohol use disorder, and after exploring more and more, right? Alcohol is just a way to treat their depression, their solitude, their boredom, right? And then we have to engage on that. Or pain.
Hi, I didn't understand exactly what you said about non-alcoholic liver problem.
Oh.
Because recently my daughter had an ALT of 400 and something, and then she had a AST of 95. And all of us, because she had a lot of pain in her stomach, and that's what they said, something about liver, something. Well, what would cause that? I heard you say something about it, but I didn't understand it.
Yeah, my
And
apologies.
then the next week, it went back down to almost normal.
Yeah, so pretty much what I was referring to is not, we as primary care doctors, some occasions we hone in that if we have an AST and ALT elevation, we send this patient to ultrasound, let's say, and the report of the ultrasound comes back to be liver steatosis. So we just hone it to, okay, so this is NAFLD. My goal with my residents and fellows is to stop that practice. NAFLD should not, that little abbreviation, acronym, whatever you want to call it, should not be utilized until we have ruled out all these potential causes, okay? Was it hepatitis? Is the person drinking too much, okay? Are we having hemochromatosis or Wilson's disease? Once we do this workup, I can say, okay, this is non-alcoholic fatty liver disease, likely due to dietary conditions. That's what I try to mean, that definitely in a quest at our department specifically, that I definitely do not want to listen to everyone telling me, oh yeah, Dr. Mesa, patient has steatosis on ultrasound, AST and ALT elevation, so I think it's NAFLD. No. Where are the results of these tests first, okay? If we rule that out, then we can talk about that. Yeah, thank you so much.
I had a question. I think, Dr. Mesa, I heard you say that in primary care, the physician cannot do all the different pieces. So how do you deal with that? I know there's obviously referrals to addiction specialists. What about those folks that are like a little bit unhappy with their drinking issues, but maybe don't need, medical treatment or detoxification? How do you help them maybe through additional relationships you have with professionals?
Yeah, okay, excellent. So there is a lot of empirical evidence. Peer support groups, they do help, okay, in any aspect of life. And it's true, right? Some patients, they say, look, I don't want pharmacology, which is okay. I don't think I need to see a therapist, okay? But I always invite them to groups nearby them. For example, I'm the medical director of the substance use department, Clínica Romero, a clinic right here in downtown LA. And that's what I invite them to do. I know of some peer groups nearby the area, and I tell them, if you don't want to come to our IOP right here, that's okay, okay? But why don't you go to visit this place? And the only way in which I'm able to help in that fashion is because I'm kind of like hyper. So so definitely I took the time to go and meet the organizers of these groups, right? To tell them, look, I might be sending you some patients, okay? I know everything is confidential. You don't have to tell me anything specific, but I just want you to know that I'm going to send you some people, and I want to sit in your group today to see how it works. If I find that that group provides a good environment for my patients, I start to send them there, okay? But definitely I had to create those connections from the get-go, because as well, there are from peer groups to peer groups, right? There are some peer groups that actually make people to feel a bit more triggered, as they say it, right? Because they feel that there is a lot of romanticizing on those days when they used to drink. So I like to sit at least for 1 or 2 sessions on each group that I know, and I recommend people to go in that fashion. So that's what I tend to. I use a lot of peer groups in this case. And when they meet me, the good thing is like, well, some occasions the patient comes back and like, you know what, I did like that place, but they told me also there is this medication that you can give me here. Now, okay, I told you about it, but now that you heard over there, you're coming back, which is okay. I can help you with that portion, right? So it's a really interesting interaction in that case. But yeah, I'm pretty hyper in that regard, that I like to know where I send my patients specifically. It takes a little bit longer, but it's just one of the due diligences that I think I have to do. Yeah.
Thank you. Hi, I had a question on maybe how your management with people with these type of alcohol use disorder may shift between different like cultural understandings of your patients, whether it's like drinking for religious practices, drinking as a form of culture, right? When we think of the people in the Latina community, drinking is a really big part of like social gatherings, like it's what we do naturally almost, right? So I guess I wanted to learn a bit about how your management on patient treatment may shift in different cultural contexts.
Okay, fair enough, right? And I'll be honest to you, it doesn't shift much, because when I start shifting from one way to treat someone to another one, okay, I'm going to add a lot of my implicit bias. If I just go by, look, all of us, we know alcohol has the potential to cause X, Y, and Z, right? All of us, we know that these are your results from your blood work, right? Definitely my recommendation will be X, but you tell me what your goal is. Well, Dr. Mesa, I like to drink my tequila because, with my compadre, every single weekend we meet and we watch America play Chivas, right? Okay, respect that, right? But your liver is telling us that's still inflamed, okay? And so I approach it from that fashion. I give my side as a healthcare provider, okay? And I do understand what their goals are. And we try to come to a common agreement on, depending on how the labs may change, we might recommend some specific changes. He can take it or not. That's up to his or her decision, right? But my recommendation will stand at the end of the day. I just will be respectful of the decision being made. Believe me, I have had patients in which I have asked, okay, look straight to my eyes, okay? your liver is X, Y, and Z. We know you have cirrhosis, you had a bleed 3 months ago. Do you want to die drinking? And some people have looked at me in the eyes and yeah, I'm okay with that. Okay, I respect that. That's as much as I can do.
Thank you so much.
Thank you.
Enjoy.
Thank you.
Thank you, Dr. Mesa. Thank you, Dr. Chung, for a wonderful morning so far. Hope everyone's enjoying their time. We're going to take a 10-minute break and we'll be back in this room for our next activity. So take a stretch, do what you need to, and we will listen for bells when we're back in this room. Thank you.
All right. Well, following up our wonderful performance, it's my pleasure to introduce Dr. Brian Hurley. Dr. Hurley is an addiction physician and also the medical director of the Bureau of Substance Abuse Prevention and Control for the LA County Department of Public Health. He serves many roles, and I'll share a few. He is the president of the American Society for Addiction Medicine. He is also the co-clinical director of the Addiction Treatment Starts Here program through the Center for Clinical Innovation, where they focus on the delivery of medications for addiction treatment in California's community health clinics. He's had numerous grants funded by both SAMHSA and the Centers for Disease Control and Prevention, working on a harm reduction grant and also a local grant award. So it's my pleasure to introduce Dr. Hurley. Greetings. Can you hear me okay? Over there, over there. All right, it's good to see everybody. So I have 10, 15 minutes to go through alcohol's harm on community health and things we can do to help. So I'm not going to repeat talks on some of the fundamental treatments for alcohol use disorder, but I do want to talk a little bit more about like the context. So I don't have any financial conflicts of interest. I am the president of ASAM. ASAM runs courses and has a membership, and I'm not unbiased with respect to ASAM. So it's not like a financial conflict. I'm not going to try to sell you anything, but you know, you should know that I'm not unbiased with respect to ASAM. When we think about alcohol, there's a lot of attention to the molecule, right? What does alcohol do to the body? I think it's also, there was a question earlier on, you know, these molecules like alcohol or other intoxicants exist, but they exist in a social context, right? So there is a difference between like using alcohol in like culturally specific ways where you're not necessarily like consuming to intoxication every single time, and then waking up and drinking all day, every day throughout the day, right? Those things are different in the amount that people use and in the context with which people use. So what is the most commonly used intoxicant in the United States? Caffeine. Caffeine. But interestingly, when it comes to caffeine, there is no, the American Psychiatric Association has not codified something like caffeine use disorder. It's caffeine withdrawal syndrome, and anyone who has stopped using caffeine for a period of time can attest to there is caffeine withdrawal. But the actual like repeated use of caffeine, interestingly, outside of a few limited circumstances, doesn't cause this syndrome of caffeine use disorder. But after caffeine, alcohol, right? And then after alcohol, we have tobacco products. Although it's interesting, we are finding lower and lower rates of combustible tobacco use and higher rates of other types of tobacco use. And then cannabis. Cannabis will probably overtake tobacco within the coming decade as intoxicant of choice for smoking. And then you have like everything else. So prescription opioids, hallucinogens, stimulants like cocaine and methamphetamine, prescription sedatives, and so forth. This is national data, but roughly 70% of Americans have had a drink in the past in their lives, right? So not everyone drinks. In fact, there's a sizable population that doesn't, but it's a minority. Like most people have had a drink of alcohol, but less than half of Americans have had a drink in the past year. Of the people that drink, roughly half are what are called binge drinkers. They drink a lot, but not by a lot. I don't mean like all the time, but I just mean have more than 4 standard drinks for men under the age of 65. And 3 standard drinks for women and people of any gender over the age of 65. And then there are heavy alcohol users that binge drink regularly. So this again comes from the National Survey on Drug Use and Health. It's national data. But our department, the County Department of Public Health, did a community needs assessment. So we have our own contracted network of prevention providers, and we actually came up with our own what do we know about LA County's relationship with alcohol use. So it mirrors national data. Roughly 70% of Los Angeles residents have had a drink in the past in their lives, and roughly 40% in the past 30 days. So we're on par with the national average. And I would agree, this report just came out. So if you're looking for information around Los Angeles County specific information, it's posted there. Lifetime binge rate, a little over 1/3, and 10% of binge alcohol in the last 30 days, which is an indication of heavy alcohol use. Now, that said, alcohol use disorder is roughly 6% of Los Angeles County residents we think meet diagnostic criteria for alcohol use disorder. So that means alcohol is impacting much more of a population than people with alcohol use disorder. Does that make sense? Not everyone that drinks has an alcohol use disorder. Now, that doesn't mean that alcohol is not impacting their liver, their kidneys, their digestive system. As been presented here, alcohol is a carcinogen. We sort of think of tobacco as a carcinogen because there's been all this branding around that, but actually alcohol is also a carcinogen, right? And so the context and the industry framing and the way that has impacted the regulation of alcohol has led to a different public perception of alcohol than what we know about health effects. If we actually look at alcohol use disorder, this is again national data. So roughly 30 million Americans meet criteria for alcohol use disorder. This is sort of past year use disorder, which is more than all other use disorders combined. Right. So if we look at the health impact of alcohol use disorder, it far outpaces everything else. But does anyone know, of these people with alcohol use disorder, how many people get treatment for alcohol use disorder? 10%? Anything else? So it's 6%. It's 6%. And of that 94% of people that have alcohol use disorder that don't go to treatment, what's the #1 reason why people don't go to treatment? Somebody said denial, but I might say unreadiness for change. Unreadiness for change. They don't go to treatment because they don't want treatment the way that treatment is usually delivered. I did not perceive the need for substance use treatment. So I work for the County Department of Public Health. We work on getting people substance use treatment. Substance use treatment cannot be the one public health response to alcohol problems because it's not touching most people. Let's be clear, right? Like most people don't go to treatment. So if it's true that most people don't go to treatment and 95% of that 94%-ish, are not necessarily interested in the way treatment is historically delivered, then it's a losing. Even so, take a step back and then I'll make the point I was about to make. So in the county, we're working on something that's called reaching the 95%. How do we get the treatment system to be more accessible to people with substance use problems? Let's say we were wildly successful with our reaching the 95% program, which we're actively implementing and working on right now. Maybe we get to 10%, which would be a huge win. It would be a doubling, right, of people in treatment. That would be great. It still would not reach the population of people that we need to reach. So if we can't get everybody to go to treatment, which I support people getting into treatment, I work on getting people into treatment, it's a good goal. But if we can't get people to go to treatment, we have to bring treatment to people. So that's one message. Is how do we support reductions in alcohol problems? We take what we know works that is in treatment and begin to deliver it in other settings of care. How many people with alcohol use disorder get medications for alcohol use disorder? Someone said very few. 2%. 2%. So, Surgeon General report, Facing Addiction in America. It is integrating substance use services that results in better outcomes. It cannot be, you drink alcohol, you need to go somewhere else. outside of here. It has to be, you're drinking a lot, let's talk about it. Let's have a conversation. Like, it's all of our kind of collective community responsibility to have effective conversations around alcohol use, which means that addiction treatment, which currently does not deliver a lot of medication services to people, needs to have integrated medication services. And we have to have addiction treatment in our hospitals and primary care clinics and community mental health centers and street medicine programs and in our housing and other social services. In other words, we need to make treatment accessible. But there's a problem with that, which is substance use disorders are so stigmatized. And the words we use are so laden in value, in sort of value language. There's actually this great implicit bias study that looked at, they gave the same information, but used different terms. And then asked, okay, like, here's a case, here's somebody, this term versus that term, what do you think we should do? And terms like substance abuser, relapse, medication-assisted treatment, overdose addict, alcoholic, were associated with this person should be punished. Person who uses substances, recurrence of use, medications, as opposed to medication-assisted treatment, but medications. Accidental drug poisoning, and person with a substance use disorder. So person, first language, actually is associated with, let's meet this person where they are and see how we can be helpful. So language, the language that we use reflects how we think reflects how we act. So just a couple of recommendations. Let's not label people. Right? Let's say this is a person that drinks, or this is a person with a substance use problem, as opposed to addict or alcoholic. Rather, like, I rarely start a conversation with somebody saying, you need to commit to full sustained abstinence from alcohol and other intoxicants forever forward. Go to treatment to do that. I start the conversation with, how can I help? Are you interested in drinking less? Not stopping, although I would love for somebody to say I'd like to stop, but that's not where I start the conversation. I start the conversation with, what changes in alcohol do you think about making, if any, right? To really understand where somebody's coming from. So language matters, words have power. I am running out of time, so I'm going to skip past a few slides and just talk about a few resources. So one of the things that I worked on, I've worked in a couple different county departments, but I used to work for the County Department of Health Services. That's the logo that's up there. We do have a 7-day-a-week telephone consultation line through which people can get access to medication services. And like, I can help you with withdrawals, and to cut back is like usually the conversation that happens with people on the consultation line. We have an e-consult service for community health centers. We have a list of community health centers that serve people who are Medi-Cal members and who are low income and uninsured, with where to get So we have a list of, like, here's the medications and other services available for alcohol use disorder. And then the county does run a 24/7 substance abuse services helpline to connect people to treatment if and when they're ready. But let me be clear, even if this, consultation line, this helpline was to be wildly successful, we also know that the demand for substance use treatment is, rather the lack of it. The lack of demand is the biggest driver of the treatment gap, not the lack of supply. We do have a list of the service and bed availability tools, and our website, Recover LA. Lists a bunch of community resources. So this is my email address. If there's any other questions, just on my conflict of interest alert, come to the ACI meeting. It's if you're like, this is great and I want more addiction doctors, conversations like this. That's going to be in Denver in about a year. The CSAM, California Society of Addiction Medicine meeting, is going to be in San Francisco this coming August, and the addiction psychiatry meeting is in Naples, Florida. And with that, I will turn it back. Thank you, everyone, for your time and attention.
Thank you, Dr. Hurley. So we're going to do a little activity, breakout activity now. We want to really kind of put into practice everything that we've learned so far and encourage discussion amongst everybody. So at your tables, you should all have a sheet, a two-sided sheet or a stapled sheet that has a few questions and some lines for writing. What we're going to do now is give you guys some time to discuss those questions amongst your group, and then we will come back and talk about it together. This is meant as kind of a community listening session, so if we don't all get to share back what we talked about, we will be taking that information and kind of compiling it for us to share back with you guys. If you guys have any questions, let me know. The questions are divided by groups, so starting from left to right, it's not an exact break, but we'll have questions about alcohol policy, community impact, alcohol marketing, societal factors, and community engagement. If you're at a table and you're not super thrilled about the topic, feel free to like shimmy over to a table over that has a topic that you're interested in. But we will let you get to it and we will call back the group in about 15 minutes. Any questions? Okay, great. Thank you. Yeah, sorry. Yeah.
So there was a, this I was sure I was meeting. There is just one effective plastic slide deck. But this is clearly going to generate this deliberate that is part of this symposium. So I'm glad. But yeah, no, happy to teach you. Just look like because I know you were the one that constructed.
No,
So
no.
There's my.
Sorry. All right, buddy, just to let you know, we'll be coming back as a group in about 4 to 5 minutes. Thanks.
That's good to see you. I think we've got. Oh, yeah. A lot of need. Maybe you bring it up on for the discussion. So my role at public health is as the medical director of the bureau. So it's prevention, harm reduction, and treatment. But my job is an administrative non-political. So when we see treatment, it's contracts. So like for example, the treatment center operates on a community contract. I oversee. I'm the medical director of the payer of Permanent treatment center or about Center for Valley Addiction. You know, like so. There's a bunch of. No, sorry, not San Fernando Valley Casino, which you don't have. Although I tried to put it as VHS to do it. But there's San Fernando Valley also on addiction. And when alcoholism and addiction is like NCADD, which is like an agency, it's like a county operation, it's like a community agency. They operate South. I'm excited to have a lot of group conversation. Yeah, there is. It's busy, but it's a different department. Yeah, I'm good to see you.
Hello. Hey, everybody, could I get your attention, please? Okay. Thank you. It sounds like there's a lot of good ongoing discussion. We want to hear all your thoughts. We would love if everyone could share all the thoughts that they had at the table. Fortunately, we have a limited amount of time. So Dr. Hurley's going to come up here, and if you have any particular comments, questions, thoughts, really good things that came out of the discussion, you can just direct them at Dr. Hurley, and it'll be kind of a back and forth. Before we do that, I'd like to introduce Dr. Wong.
What time do you want me to start? We had this conversation at our table. I'm Winston Wong. And actually, Dr. Hurley, you might be in a good position to respond.
We will see.
So we haven't heard the conversation with regards to, is there genetic dispositions to any group of human beings towards substance use, addictive behavior, and alcohol use disturbance? In other words, should we take on also a much more scientific clinical perspective as opposed to just the question of social policy and how that impacts a group of people? So given there's about 300 people here, maybe about 20% of us are more susceptible towards alcohol and its impact on recurrent damaging use.
Thank you. Implied there is a question. So I'll say, Dr. Shuckett at UCSD spent a career characterizing the genetics of alcohol use disorder. Roughly 50% of individual susceptibility to alcohol problems is inherited, right? So this is really, and now that said, genes are expressed in an environment. So this like genetic versus environmental dualism is in fact not a dualism. It's they sort of feed on each other. So there are genetic things we inherit genetically that can protect us from alcohol use disorder. So people who are more sensitive to alcohol are interestingly less at risk. So people who are susceptible to buildup of alcohol dehydrogenase in the system, are less susceptible to alcohol use disorder. And a low responsiveness to alcohol is interestingly means that we drink more, and interestingly is associated with a greater risk. And then there are also genetic risk factors in our liver and other parts of our digestive system. This is not going to turn into a lecture other than to say, yes, there are absolutely genetic differences. And in this room, there are certainly genetic differences. But one of the things that's so frustrating is I'm not a hepatologist, I'm a psychiatrist, but my hepatologist colleagues treat patients and they're like, but I don't drink more than my friends. Why is my liver all messed up and theirs isn't? And the answer is it's not just about how much alcohol you drink. You know what I mean? Like there are individual level differences. And it is unfortunate that there are some people like truly that like it's higher risk for them to drink because of their genetic makeup. Okay, this is a listening session, forgive me. Alcohol policy, community impact, marketing, societal factors. What came up at your tables? So did anybody discuss alcohol policy? And if so, what came up? Hand right here.
So for alcohol policy, I would say the best conversation we had to do with, it would be number 4, which is what types of policies have you seen as most effective or do you think would be most effective in addressing alcohol consumption and harm? So we listed things like the enforcement of DUIs, the organization of MADD, Mothers Against Drunk Driving, who have brought a lot of awareness. This was Mothers Against Drunk Driving was more of a grassroots movement that brought awareness to a need throughout the country, and led to stricter enforcement of DUIs and alcohol regulations in terms of driving.
Mm-hmm.
So that's we also use the example of the seatbelt. That's something that wasn't normalized until a recent history. So, and look how normalized it is now, just like a DUI.
Mm-hmm.
So a small policy change can lead to a lot more benefits.
Thank you. Other alcohol policy? Community impact? Oh, sorry, there's a hand over there. Thank you.
Hi, my name's Nakia. I'm Executive Director of Therapeutic Play Foundation. And my table, we were sort of talking about community impact in that alcoholism, substance abuse, and all that good stuff, generally from my perspective, has been in relation to disassociation, like somebody truly coping, self-medicating for not having enough resources, worry. And also it's more socially acceptable to self-medicate with alcohol because like we're growing up and we're talking about in Italy, people just wake up with wine, breakfast, lunch, and dinner, or like in Britain that there's tea that babies grow up with. And yes, that's not alcohol, but like it's the actual habit of using something else to calm ourselves down as opposed to it being internal. And I think that's a systemic matter. You know, if people feel safe and able and connected to community and they have housing and food and shelter, most likely they have time to think about themselves and take care of themselves. And that's a policy matter. And I think that's why we have to continue to talk about it being a policy matter, because communities are impacted every single day when our mindset is not right. And alcohol impacts our mindset. So it's a circular conversation.
Thank you. Yeah, one of the things that you brought up, you know, John Hari is a journalist that talks about the opposite of addiction isn't abstinence. The opposite of addiction is connection, right? And so imagine if every child in LA County was nurtured and supported and had healthy emotional development. Like imagine what that would do to the alcohol rates. So I appreciate you bringing that up. Imagine we could eliminate poverty and social inequality and structural violence against all sorts of communities, but that is also a political and policy conversation. Okay, community impact. Yes, thank you.
All right, so this lovely table is the community impact team, at least for today, as far as the listening session. So some of the biggest challenges that we did discuss was access to treatment. I know there is the treatment that's available, but some of the issues that we brought up were the time appointments are available. Typically, a lot of service providers like to stick to the 9 to 5. I myself have had the experience of helping someone try to access treatment at least twice. And that was a very interesting challenge. So I think that even making that, kind of approach or the connection definitely easier would be awesome. We also talked about the proximity of liquor outlets to youth-sensitive locations, the use of alcohol as a normalized kind of coping thing for celebration, for good times, bad times, all the times, being glamorized on social media. And then as far as the issues that we are seeing that prevent people from getting treatment, we talked about money. The lack of money and time to be able to go to these outpatient programs or inpatient programs. Again, speaking from personal experience, I had a family member that was trying to get into treatment for alcohol and decided to go the outpatient route so they could still work and provide for their child. But what they found was they had difficulty getting there. And if they weren't there right at the start of the program, they weren't allowed to be attending the program. So I think, just making these resources more practical for like the everyday life and considering those barriers. And also talked about language not being offered outside of English in some cases, and then also plain language. Many times that these folks that are coming in here trying to get help may not understand all of this technical medical jargon, and really looking and hoping for people to explain that to them. So.
Thank you. Alcohol marketing. Over there.
Hi, just kind of reporting back. We talked a lot about the concern with marketing and specifically around communities that are most impacted with the lowest health outcomes and how we continue to see the type of excess in marketing in these communities. And so I guess trying to open up to the group of like, what are some of the strategies that we can consider, given that there is a lot of deregulation that allows for an excess of marketing to happen, especially in those communities that have been historically flooded with outlets and advertising, and just goes hand in hand with a lot of what's already been said. I think that we also wanted to kind of emphasize the reality of the way that the targeting has really expanded with this era of social media and all of the influencers and the celebrity spokespersons, and just the reality of the front that's being provided with the marketing, where none of these celebrities really own any of these products. It's really just the fronting of it. So we talked a lot about that. And how disproportionately it continues to be targeting people of color and flooding communities of color, more low-income communities versus more affluent communities, and how it continued to evolve during the pandemic. And we saw a lot of it in social media. You could order alcohol from your streaming platform, and just the lack of regulation that there is on advertising now on all mediums that is even a lot more blatant. And there's no actual restriction around like even children and what access there is. So we did talk a lot about what that looks like now and how it just continues to escalate and there doesn't seem to be much restriction in the volume of advertising that we're being flooded with, and that it just continues to just perpetuate the problem. But I'll open it up to anyone else who wants to add anything from our group or others.
Additional thoughts on alcohol marketing? Anything else? Societal factor. Oh, sorry, alcohol marketing.
Hi there. So my group, we talked a lot about how marketing really glamorizes alcohol consumption and how it's all about having fun and being social and having a good time. And it's not really expressing like the negative outcomes of consuming alcohol and just how like easily accessible it is to have alcohol. Like you see it at sports games, you see it at the restaurants, you see it at amusement parks. It's really just everywhere. And it's everywhere in the media. You know, you see it not only through like commercials, social media, celebrities and influencers, but just in regular movies and TVs, everyone in there is drinking alcohol or they're making a drink. And it's just so prominent in everything that we absorb. And it's all about like the fun and, you know, being glamorized. There's not really a lot of focus on how it affects your health and how it can negatively affect your health. And we talked a lot about that.
Advertising is not truth. Yeah, thank you. Societal factors? Thank you.
So when we talked about societal factors, we kind of talked about how in certain cultures, it can be more encouraged to drink with the connotation of like, oh, you're not man enough or woman enough if you don't drink, or responding to everyday stresses of life. I think it's, we said it's more normalized and has like in reference to stigma, maybe less stigma as opposed to using drugs because it's legal. So I think that societal rules and influences definitely plays a factor.
Got it, thank you. There and then there.
Hi there. We also talked about the normalization of it and that in certain settings, alcohol consumption is almost mandatory. You know, that it's expected. So at sporting events, there's, you know, beer everywhere. You know, I talk personally about, you know, my Latino community. And when I go to quinceañera or a birthday party, even at grandma's house, it's like we're all having a little tequilita at the very end, you know.
And that's an expectation.
That is an expectation and it's always available. So, and there's never really an option of not having it available at these parties or at these social events or even family events. Looking at what are the contributing factors, we did touch on social media. I mean, that's where everybody is now, you know, so what are some ways that we can leverage social media to change the narrative? But also looking at, like, for me, I showed the example of education. Like I'm very much a data geek. I love learning how things affect my body, but I'm also a cancer survivor, you know, not everybody wants to know on the education side, like not everybody's driven by that. So how do we leverage stories as a way to educate the community? And also, you know, looking at workplace, there's always like stressors and everybody talks about, let's go have happy hour after to de-stress. So looking at alcohol as a way to manage stress is what's widely shared out there. And also mommy wine clubs, and, you know, that's normalizing again, drinking wine as a way to cope with motherhood or, you know, parental responsibilities. So there's just a lot of work to be done in this space. Did I miss anything? Okay.
Thank you.
We thought and had the same conversations as all the ones that we've heard thus far in relation to all the different topics. And one thing that we kind of maybe spend a lot of time on is talking about the legislative process. And in our society as Californians, and we're in the best state and the most progressive one. And when Dr. Chung was talking about prohibition and how positive it was and how it worked, well, what type of legislation could be introduced at this point to try to decrease the numbers in all communities in California? And what we came up was increasing the legal drinking age to 25. And strategically, at this point where the voting population is more so over 25 now, before, you know, the youth can vote more, because at 25, that's when you can rent a car. At 25, that's when your brain is finished developing. So, you know, we kind of got into a discussion about how things would have been so different if it's not 21, go celebrate, go drink. A focused teenager at 25, they may be finishing up their master's degree. So, you know, it would be very, very different goals that they could reach if drinking wasn't a part of it at 21 years old. So that's kind of where we went with the awareness and what we could do as a state, being Californians, and this is our society.
Thank you. So we have lots more comments than time, unfortunately. I'm sorry. What I would suggest is please, during the break, bring up some of what you discussed in collective conversation. But with that, I will turn it over to our conference organizer. Thank you, everybody.
Thank you, Dr. Hurley. I'm actually going to turn it over to Andrea for our next portion.
How's everyone doing so far? We're doing good still? Okay, good. So as you all saw, we've heard from amazing speakers. We saw a beautiful performance earlier. And so now we're going to turn it over to our amazing Community Seed grantees. Like Dr. Bastani mentioned earlier, these are our grantees. These are dedicated and talented organizations that work to solve health equity and address health equity issues in their own community. So I'm sure you all saw them outside of these doors. So when you're available to, please take these next couple of minutes to go outside and explore, take some time to talk, walk around, visit all of these posters, and really get to know these amazing organizations that are doing the great work that we're talking about here and that they're applying it to their own community. So please take a moment to go outside and visit some of these posters. And then also you can grab some lunch afterwards so you can eat and then watch over some of the posters. What time should we be back? And please be sure to be back here at 1 o'clock.
Yeah.
We could do it to the home, yeah. Yeah.
Hello, love.
lot of animation.
Really like that.
Yeah, he apologized. He's like, oh, I think I'm gonna broke.
I was so worried. Yeah, and I was like, wow. Or like punch the podium. Oh, yeah. I was like, she's back. I was getting ready to like. No. I'm not gonna stand here on the stairs.
They even have to do rows.
Lena!
It's too long.
Come on! Yeah.
Oh, a sorority
squad?
Sorority
squad.
Because we like each other. We do the sorority.
Lena, Lena.
Yeah.
Yeah,
Lena. Come on, Lena.
Came a long way.
Yeah, I know.
Come on, Lena. Vanessa's like, I could hold this squat for a long time. Ready, set, go. It's hard. You want to go. Okay. I was like, I come back. Yeah, you might. You don't want to block Lena, but Lena, squeeze it.
We can Photoshop him in.
That would be cute. 3, 2.
Thank you.
Did you ever work with Dr. Yeah, I actually, I met him when I was a fellow. Oh, and then oh, you're doing like such great work. Like, I want you to connect to our hepatology program.
Yeah.
Because we need transplant and there's like no.
If it's changed on here, then this is yeah. They wanted all faculty to do stuff. Where's that? Verdugo, Raul, right? Yeah, this is what it is. Yeah, thank you.
Sure, when you're dealing with a scarce resource, sure.
Right.
But the reality is,
Yeah.
And then so connected him with our transport program, and he's like part of our committees, and he whenever we evaluate like he'll help evaluate them too. So it's just nice to get like a professional expert.
I'm sure, in a more realistic like plan of how to move forward.
Yeah, it's like if this person, because they have like, let's say a short career sobriety, like, okay, what, and they're learning about things that just found out, like, as they're, like, I'm sick in my liver, alcohol. So like, what do I do then? Like, is it, okay, you're insight, but oh yeah, I wish I would you, blah, blah, blah. And it's like, okay, then how about moving forward if this guy, what would be, kind of how like write it out of the listing too. Their insurance is this, so they can connect with these resources. I have a colleague here because it's medical. This is like great. Like
No, it's
that
so
is now
important.
comprehensive.
No,
now.
it's true, and like that's what you need. My friends,
Yes, that's the end of the day.
Well, let me know. She's gonna do it with page one. Oh my God, I should. Well, if you start, sometimes I have a wall. While I'm wondering, that's what I do. I start to tell people, then I feel like, okay. Next time I see them, they're gonna say, it's a little social pressure you can create for yourself, yeah. I'm so glad you came after. No, no. Comenzamos aquí. Pero vamos a ver, ¿no? Yo voy a estar allá. Tú vas a estar en medio y vas a tocar al toquido del tubo. Vamos a comenzar uno, dos, tres.
Oh, okay, sorry, I was supposed to check my doctor. And your vision, you can take 5 minutes. Everyone, I hope you enjoyed your lunch. We're going to be starting here shortly, so if you could get back to your seats and get settled. Thank you. Oh, no, yes.
All right, welcome back, everyone. I hope you enjoyed your lunch, had some time to visit with old and new friends, soaked up a little sunshine. We're excited to get started with our afternoon keynote, get back into some really interesting discussion, and we're very honored to have Dr. Priscilla Martinez here with us today. You have her bio at your table, but I'm going to just pull out a few key highlights. Dr. Martinez is a scientist and deputy scientific director at the Alcohol Research Group, which is a program of the Public Health Institute, and she also has a position at UC Berkeley. Her transdisciplinary research includes a focus on understanding and reducing alcohol-related racial and ethnic health disparities. As study director of the National Alcohol Survey, her work also examines alcohol survey methods and ways to improve participation of racial and ethnic minorities in alcohol survey research. Alcohol's harms in the general population and health messaging to increase awareness of these harms. So please join me in welcoming Dr. Martinez.
Thank you so much for that introduction, and thank you to the organizers for inviting me. And thank you to all of you for being here. I am just giddy to have this chance to share this space with you and to have a conversation about how alcohol use drives some of the health inequities that we see in the US today. I'm going to repeat a little bit of what you've seen already. Researchers, we love to repeat ourselves, and I think sometimes it's okay to hear the message a couple times, but I'm not going to linger too much on things you've already heard. I don't know how to make this work. Thank you. Success. So I'm gonna start where I normally end, and that's with take-home messages. So I did this for a couple reasons. One, you can listen to these take-home messages, and then you can have a nice little post-lunch nap because you'll have gotten the gist of the talk. And I also did it because this is how I've structured the talk for today. I'm gonna do it by these two take-home messages. Take-home message number one, reiterating what you've already heard, alcohol is not good for health. And I'm being a little bit cheeky when I say this because this is an understatement. The CDC estimated in 2020 to 2021 that about 500 people die a day from excessive alcohol use. That's a lot of people. We know that alcohol is not good for the individual body, and it's not good for the population or the public's health. So when I talk about this section and this take-home message, I'm going to get a little bit of alcohol use 101. I'm not going to torture you too much with definitions and statistics, but I am going to a little bit just so we're on the same page about what I mean when we're talking about alcohol use. I'm then going to talk a little bit about what alcohol use looks like in the US today. You've seen some of the stats I'm going to show already, so we'll go through those quickly. I'll talk a little bit about alcohol's effect on health, and then I'll talk about what some of the health inequities we see that are related to alcohol use. Take-home message number two is a little bit more about what drives these inequities that we see. And yes, our physiology matters, but I might argue that environment matters more. And I'm using environment in a really broad catch-all way. I'm talking about the physical built environment around us, the social environment, which we've touched on today, the consumer environment, the policy environment, the socio-political environment. There's a lot going on when we talk about what drives health inequities in the US that are related to alcohol use. I'm not going to go through all of those environments. We would be here for the rest of the week, but I'm going to focus on the physical environment, and a little bit on the consumer environment, and talk about the social environment. Alcohol use 101. So when you hear about studies saying we found that alcohol use is associated with this health outcome, the basic unit of measurement that we use is a standard drink. And what is in a drink? In the US, we define a standard drink as containing 14 grams of pure ethanol or alcohol. Pure alcohol is ethanol. And you can get 14 grams of ethanol by having a 12-ounce can of 5% beer, a 5-ounce pour of 12% wine, and then a 1.5-ounce shot of 40% liquor, which is usually what liquor's at. There's two aspects to this that are really important. One is pretty obvious. The other one, I think we often forget about. So volume, the size, right? 12 ounces, 5 ounces, 1.5. That's a little bit more intuitive. If your drink is larger, you might think, okay, well, I'm getting more than a standard drink or a little bit less. That makes sense. The alcohol content is a little bit less intuitive. And this is partly because it's on every alcoholic beverages, but we don't always pay attention to it. And we've seen the emergence of craft beer in the US, and on average, the craft beer ABVs are closer to 6.5%. And this makes a difference when you are thinking about how much you're drinking, because oftentimes we're actually drinking a little bit more than we think we are. US drinking guidelines. Most nations have some kind of guidelines for low-risk drinking, and then they have definitions for binge drinking or alcohol misuse. In the US, our guidelines are gendered according to the gender binary. This is a little problematic just there, because what do we tell our transgender and non-binary community members? Is it based on sex assigned at birth? What if they've gone through gender affirming treatment? What do we tell them there? We actually don't have the research to answer those questions. Some of this work is being done now, which is great, but we don't really have any answers yet. So according to the male-female binary, for women, low-risk drinking is 1 drink a day. For men, it's 2 drink in a day. Not that you should have 1 drink every day. Binge drinking, 4 or more for a woman, 5 or more for a man. And then heavy weekly drinking is 8 or more for a woman and 15 or more for a man. When we talk about these guidelines being low risk, the question we should all be asking ourselves is low risk for what? And in this instance, the guidelines were developed with an alcohol use disorder in mind. They didn't consider all of the other health risks and harms associated with alcohol use. So this isn't exactly a disclosure of a bad thing, but I'm on the scientific review committee for the new guidelines that are going to be coming out next year as part of a whole new dietary guidelines for Americans. And what we're doing differently this time around is that we're looking at how alcohol is associated with all the harms it's associated with, particularly its health harms, and what that would mean for the guidelines. And to be clear, we are just conducting some studies and presenting our findings. We do not make the recommendations. That is up to Congress. When I talk about alcohol use, I think it's kind of nice to know where we've been and how things have changed. And you've kind of heard this, so I'm not going to dwell on this. The takeaway message from this slide is that alcohol use has gone up. In the first couple of decades of the 21st century, it's gone up among both men and women, and it's gone up a little bit more among women than men. And we see this among different racial and ethnic groups. This is only for Black people, Latino people, and white people, but again, we have men on top in greenish and women on the bottom in orangish. And we see increases across the board. We see a slight decrease among Latino men, but that wasn't statistically significant. And so, these are data from our national alcohol survey that we run at the Alcohol Research Group. Okay, so this is now really a pop quiz because you got the answer to this earlier today. So what percentage of people in the US who were 12 and older drink any alcohol in the last 30 days? How many people think it was 30%? None, a few people. Okay, how many people think it was 50%? A few more, 60%. Even more, and 75%. How many people think it was 75%? Okay, the answer is 50%. So you were not paying attention earlier. I'm just kidding. So these are the National Survey on Drug Use and Health data that come from SAMHSA. And yes, this is 12 and older. So you might think it might be a little bit higher, but young people aren't really drinking very much. So about 49% of the population reported having any alcohol in the last 30 days. Of those, about 45% were binge drinkers, and then about those, a quarter were heavy alcohol users. And you heard this earlier, so we're gonna move past that. The other interesting thing about alcohol use in the US is that it varies across different sociodemographic groups. So on the left, you have drinking by race and ethnicity, and on the right in green, you have it by level of education. And when we look at the chart in blue, we see that any alcohol use in the past year was highest among white people compared to all the other racial and ethnic groups in this that are here. And past month binge drinking is the highest among Native Americans, but lowest among Asian and Black people. And then we see the same thing for heavy alcohol use. We also see a different pattern when we look at level of education. So any past year alcohol use is most common among people who have a college degree or higher. Past month binge drinking is highest among people who have some college education. And past month heavy alcohol use is actually just about the same across all levels, although slightly higher among some college. So alcohol use is really common. It's been increasing. Why do we care? We care because alcohol is causally related to over 200 diseases and injuries. And the ICD-10, that's the International Classification of Diseases, 10th edition. It's the big fancy book that defines diseases and injury conditions. And alcohol is related to over 200. And you've heard a bunch of this earlier today about cancers and other organs that alcohol affects. And it's important to note that the risk relationships between alcohol use and these health outcomes is different for different health outcomes. So, for example, when you tell people that alcohol is related to whatever health outcome, most of the time they'll say, well, how much can I drink? Like, how much can I drink before I really increase my risk and it gets bad? And the answer is that it's different for different health outcomes. For cancers, it's a pretty linear relationship, and there's no safe level of use. Like, one drink is going to increase your risk of cancers. We see a different kind of relationship with other health outcomes. For example, diabetes, it actually starts, if you look at a graph, it's pretty low at low levels of use, and then it ticks up when you get into higher levels of use. So this makes it a little bit complicated when we talk about how we communicate to our communities alcohol's effects on health. And it also makes it a little bit tricky when you hear in the news that alcohol, a little bit of drinking is good for some health outcome, because we oftentimes then forget that it's also negatively related to 199 plus other health outcomes. So this is part of our challenge, but this is what we know about alcohol's relationships to some health outcomes. Another unique thing about alcohol use, or alcohol, especially when you compare it to things like tobacco or high-fat foods, is that it has acute effects. So we drink a lot, we get drunk, and then stuff happens. And that doesn't really happen necessarily when you have a large bacon cheeseburger. And some of these harms are harms to the self, and some of them are harms to others, and some of them are both. So we know that being intoxicated is associated with violence, domestic violence, car crashes. So there's all kinds of unique acute harms that we get from alcohol that we don't see with other lifestyle behaviors in the same way. So you might think, okay, people who drink more are going to have more alcohol-related problems. And in some cases, we see that. Among some groups, for example, among the Native American community, we see higher rates of alcohol abuse, we see higher rates of alcohol use disorder, we see higher rates of harms. And among the Asian community, in contrast, we see lower rates of alcohol use and lower rates of harms, although I will note that researchers right now are doing a pretty terrible job of looking at the Asian community because it's not a monolith, right? And we know that it's comprised of many different groups, much like the Hispanic Latino community. And there's differences within those groups. But at the national level, that's what it looks like. But then among other groups, we don't see higher rates of use and higher rates of alcohol-related problems. We see lower levels of use, but higher rates of alcohol-related problems. And therein lies the injustice, right? That's really just not fair. That's not how it should work. Therein lies the inequity. So what are some of these alcohol-related health inequities? So some of them are the physical health outcomes that we've been talking about. Hypertension, diabetes, cancers. We see higher rates of these physical health problems among marginalized groups than we do among more advantaged groups that we know are using alcohol more. And I want to be clear that I'm not saying that these higher rates of these health outcomes are totally because of differences in alcohol use or that they're totally alcohol driven. Disease is a really multifactorial, complex condition that has a lot of different factors contributing to it. But we know that alcohol is related to these health outcomes, and we know that there are inequities in them. We also see inequities in alcohol-related mortality. And so this is dying from a 100% attributable alcohol cause. A study came out in 2020 that looked at alcohol mortality between 2000 and 2016, and it was highest among Latino men compared to all other racial and ethnic groups, even though we know they don't drink as much as other groups on the whole. And then in a really important place that we see a lot of inequities is in the social consequences related to alcohol use. We see more alcohol-related social consequences, such as violence, interpersonal problems, among marginalized populations compared to more advantaged populations. A study done by one of my colleagues, Dr. Nina Mulia at ARG, found that Black people were 4 times more likely to experience just one negative social consequence related to alcohol compared to white people at low levels of alcohol use. And they were 6 times as likely to have 2 alcohol use disorder symptoms at low levels of alcohol use. That is not fair. Another, what I see as a health equity issue is in simply the awareness that alcohol has negative effects on our health. So this is something that I study. We conducted a survey of 5,000 women across the US, and we found that only 25% of them could identify alcohol use as a risk factor for breast cancer. 25%. So 75% don't know. And then we found differences by level of education and by race. So we've found lower levels of awareness among women with lower levels of education, and we found lower levels of awareness among Black women compared to Latinas and white women. And these were statistically significant for those of you who care about p-values. And so why do we think we have this really low awareness? There's a lot of reasons, and I'm happy to talk more about them later. But one reason I want to highlight, because we're talking a lot about communications, is pinkwashing. So pinkwashing is when a company that is selling a product says, I'm selling this product to support this cause, and then the product itself is something that makes that cause worse. We see it all the time in October during Breast Cancer Month when the pink ribbon is on bottles of wine and all other kinds of products. And I think it contributes to this lack of awareness because it kind of muddies the conversation. You think like, well, but wait, that company's doing something good, so that product can actually be bad. And it just makes it difficult to make a clear message about alcohol's health effects. I would be remiss if I didn't mention our Drink Less for Your Breast campaign. We conducted this in 2020 and 2021, and I had a wonderful conversation with Jennifer Metz here about this. She had a poster out there. She was a seed grantee because they use some of our materials in their effort to raise awareness about the link between alcohol use and breast cancer among the Latinx LGBTQ community in LA. So we've been talking about what some of these health inequities look like. I've given an example of something that we've done to address it, but let's talk a little bit more about generally why we see these alcohol-related health inequities. Environment matters. It matters that there's drive-through liquor places. So I'm going to start with the built environment, physical environment, the spaces we occupy. I was born and raised in San Francisco, so I totally admit my bias. LA, I still love you. So I think one of the big things about the environment that matters is where we get our alcohol. Right? So researchers study a lot. Alcohol researchers are really interested in alcohol outlet density. And what that means is it's the number of stores where you can get alcohol and the distances between them. So, how much do they cluster in an area? There are a couple of different types of alcohol outlets. We have our on-premise outlets, so bars, restaurants, places where you go and sit and have a drink. And then you have your off-premise sites, and that's where you go to buy alcohol and then drink it someplace else. And some states have outlets where you can do both. California does. Like if you think of a wine bar, you can go there and have a glass of wine and you can take a bottle of wine home after you pay for it. So there's a really robust literature that shows that the density of alcohol outlets is associated with alcohol use and with related harms. So when the alcohol outlet density is high, you're likely going to find high rates of alcohol use and high rates of harm. When alcohol outlet densities increase, you'll see an increase in excessive alcohol use and related harms. This quote is from the Task Force on Community Preventive Services, and they wrote a really nice report that summarized some of the findings and made recommendations for addressing alcohol outlet density, and you can find that on their website. I want to give an example of what a study has found about alcohol outlet density's effects on alcohol use. And this is a nice example because it was a natural experiment, and it also talks a little bit about how the scientific approach matters. So in 2009, Lubbock, Texas decided that it was going to increase the number of licenses it gave out for off-premise alcohol outlets. And so that happened. And then some researchers said, well, let's see if that impacted the amount of violent crime in Lubbock, Texas. And they did a study and they said, no, it didn't make a difference. And there had already been a good amount of literature showing a relationship between alcohol outlet density and violent crime. So another group of researchers said, well, maybe it wasn't that crime overall went up, but it was about the crime being moved around in the city. So maybe it got redistributed to another part of the city. So overall, it would have stayed about the same, but this area might have seen an increase. And that's what they found. So they took a census block where the increase in alcohol off-premise outlets happened, and then they looked at the neighboring census block, and they found that after they increased the number of outlets in that area, the neighboring area had almost a 15% increase in violent crime. So there's a really robust literature showing this, and studies have found this all over the US. And this is not an exhaustive map of dots across the US where studies have been conducted looking at alcohol outlet density and violent crime and other harms, but it really is something that is all over the US. And I'll also note that it's not just alcohol outlet density, so just the number, if you have a liquor store on every corner, but it's also about some of the characteristics of that outlet, like how many hours a day it's open, how late does it stay open, how early does it open. Those kinds of characteristics of the outlets also impact harms in the areas around those outlets. Okay, so another question for you, and this is the only other one. There are more alcohol outlets in higher income neighborhoods than lower income neighborhoods. Is that a true or false statement? Who thinks it's, okay, I'm hearing false. All right, good, well, yeah, you're so active, it's great. And you're right, you're absolutely right. And I mean, we see it everywhere. And there's a lot of reasons for this, which we can also talk more about, but we see that alcohol outlets tend to cluster in neighborhoods that have been historically disinvested in. And it's important to note that this happens even though we know that low-income populations on the whole drink less than their wealthier counterparts. And so that's something that drives some of these alcohol-related health inequities that we see, because we're putting more alcohol outlets in an area where we know that a higher density means more problems, even though they use less on the whole, and they end up experiencing more problems because of this greater density. Talked a little bit about this, so you kind of already know that alcohol marketing makes a difference, but I'm just gonna bring this message home. Advertising is designed to sell. And we know it's effective. There's a whole ton of research showing that the amount of exposure you have to ads increases both your intention to drink and then whether or not you actually do drink. And ads are also designed to inform about different products. And they also contribute to our social norms around alcohol use and to our attitudes towards alcohol use. And we know that it's not just the amount of advertising you see, but the type of advertising can also make a difference. So for example, ads that have price discounting or, like buy one, get one free, 2 for 1, I think that's the same thing, but you know what I mean? Those are associated with an increase in both use and with violence. We also see that ads that sexualize women's bodies and play off the existing gender power imbalances that we live with contribute to violence specifically against women. A study done in San Jose in the Bay Area, which is, I'm sure many of you know, has a really large Latino community. They looked at the density of ads that featured Latinas in various states of undress. And then they looked at police reports of sexual violence against Latinas. So it was very specific, and it really was just sexual violence. They took out all other kinds of assault. And they found that the higher the density of these ads, the more likely Latinas were to experience sexual violence. So it really does contribute to the harms that we see, just the number of ads and the type of ads that are out there. And then, as was mentioned earlier, we live in an age of social media, and social media makes a difference too. This is a really nice quote. It was the title of a paper, saw it on Facebook, drank it at the bar. And there's a really robust growing literature showing that seeing more ads on social media increases intentions to use and also actual use. And a lot of this work has been done among youth and young adults, although there's evidence that this is relevant for the adult population as well. And it's not just seeing the ads, because this is what makes social media unique and really appealing, is that you can engage with it. So liking the ad, sharing the ad, commenting on the ad, those behaviors are even more associated with alcohol use above and beyond just seeing ads on social media. Alcohol is a social lubricant. We do it in social settings. We've talked about this a little bit already today. Alcohol researchers, when we study social norms about alcohol use, we talk about descriptive norms and we talk about injunctive norms. And descriptive norms are what you think other people are doing. And injunctive norms are what you think other people approve of. So these are pretty different concepts, but both are related to increased alcohol use. So if you think that everybody is doing something, even if you don't think it's okay, or you think other people don't think it's okay, you're still more likely to do it. A lot of this work has been done among college student samples. They're kind of a captive audience for a lot of academics, but we see this also in adult populations. And this quote, everyone else is doing it, so it's not just me, is not something I just made up. It's from some qualitative work that we're doing, looking at people's motivations for drinking during the COVID-19 pandemic. So it's COVID specific, caveat, but I thought it really nicely illustrated what this person was doing and the effect of social norms. And she was talking about how she was seeing all these cocktail recipes on social media and how all of her friends were going to Zoom happy hours. She was like, well, everyone else is doing it, so it's not just me. And that kind of made her feel a little bit better about it. So social norms really make a difference, and we have a lot of evidence to show that. Another aspect, there are many other aspects of the social environment that matter, and not all of them mean more alcohol use. So there's a really strong literature showing that being affiliated with a religious group or being spiritual is associated with less alcohol use, less substance use in general. We know that recent immigrants are also less likely to use alcohol, and they continue to use less alcohol as they stay in the US and become more acculturated, theoretically. And we know that there are cultural norms, we talked a little bit about this, that can influence alcohol use. And a lot of these cultural norms can be gendered according to the gender binary, where it can be okay for a man to behave in one way and drink heavily under certain circumstances with certain people, but then it cannot be okay for a woman to exhibit that same kind of behavior. So it gets pretty complicated, but all of these things make a difference for whether or not we choose to drink, how much we choose to drink, why we choose to drink, who we're drinking with, where we're drinking. I wish I didn't have to have this slide up here, because we are living in a time where discrimination and stigma are rampant and really make a difference. So we know that experiencing discrimination and stigma increases alcohol use. And this is unfortunately an important part of our social environment, especially in the US. It's been associated with more binge drinking, with more heavy drinking. It's been associated with more alcohol use disorder. And to be clear, alcohol use disorder is not defined by how often or how much you drink. You get diagnosed with an alcohol use disorder because you're experiencing problems from your alcohol use. So that's like problems at work or at home, not meeting your responsibilities, craving it, like really craving it all the time, and then symptoms of withdrawal. That's how you get diagnosed with an alcohol use disorder. And so discrimination being associated with that really speaks to the strength of the discrimination and how much alcohol people who experience discrimination are using. And a lot of this work has been done among the Black community, but we also see this in other marginalized populations, that discrimination is associated with alcohol use. We see it among, there's actually a really nicely growing literature on discrimination among the Hispanic Latino community and its association with alcohol use. We see it among the Native American community, and importantly, and unfortunately, more and more, we see it among the LGBTQ+ community, which I think given the current discourse around being transgender, being non-binary, sexual orientation is not surprising, but has real consequences. Some people are working on interventions to address experiencing discrimination and using alcohol. So interventions to help you find better ways to manage being discriminated against so that you don't use substances. I think that's great, but I find it a little, not exactly victim blaming, but along that spectrum. I would really rather that we just didn't discriminate against each other, but this is the reality of where we are today. And some of these interventions, especially among people with an alcohol use disorder, are shown to be somewhat effective. They've been shown to be not quite as effective among the LGBTQ community. The other thing I want to note about discrimination is that a lot of the literature we have so far, a lot of the science is about interpersonal discrimination. So somebody, calls me a name or something like that. It's those kinds of experiences that have been studied. What's been studied less is institutionalized discrimination and structural discrimination and systemic racism. And the field is starting to move there. We're coming up with measures, like, that's always the researcher question is how are we going to measure it? And so we're starting to come up with measures of systemic discrimination and structural racism. But we still have more work to do in that area. So I've just come up here and said a lot of alcohol, bad, 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 and reasons for it, sad, sad, sad. But we are not without recourse. And I think a lot of what we're going to talk about for the rest of the day is some things that we can do. So I'm not going to dwell on these things, but I do want to touch on them, because I think in our next session, we'll be talking more about policies and what we can do. But so we know we have things that work. Some of them are deeply unpopular, like the most effective one, taxes. The WHO has a best buys document that describes some of the policies that would be most effective. And a lot of these are designed to reduce excessive alcohol use and its related harms. A lot of these are feasible. You can modify them for different circumstances, different regions. Some of them aren't expensive to implement. Some of them, once you get them going, you don't have to spend a lot of time maintaining them. Some of them raise or save money, like taxes. And they're all, or the vast majority, are supported by what we see in the literature. So the science really backs up that if you enact these policies, you will see these changes. And they can, some of them quantify how much of a change you can expect to see. So alcohol policies, I think, speak to how much the environment matters, but they can really help make a difference in reducing some of the alcohol-related harms and resulting health inequities that we see. We also have best practices, and one of them is community-led solutions. And this is part of the reason I was all like excited to be here because it's the populations that are affected by alcohol use that need to be part of the decision-making of how we're gonna address problems with alcohol use. It can't be some outside group coming in and saying, you need to do this because we know it's gonna work, because then it's not gonna work. The communities really need to be sat there at the table and work, and really working together with other people and other stakeholders. And researchers, now and again, we can be useful too. One of the things that we're really good at is collecting data and analyzing data, and we're getting better at sharing data. So our National Alcohol Survey data, we've been running the survey for 40 years and we do it like every 5 years. Most of it's publicly available. And I'm the one responsible for deciding who gets it, and everybody gets it. But it's everybody gets it, who asks for it. The CDC has the alcohol-related disease impact site, ARDI, as they like to call it, that tells you by sex and age, alcohol-related harms. You can look at it by state, you can look at it nationally. There's APIS, the Alcohol Policy Information Systems. So there's a lot out there that researchers can help contribute to informing how we can address alcohol-related problems in our communities. So for those of you who aren't familiar with the idiom of being behind the 8 ball, or who, unlike me, didn't spend probably too much time in college playing pool, being behind the 8 ball means that you're in a difficult place that's hard to get out of. And to get out from behind the 8 ball, you have to kind of maneuver, you have to hit the ball against the sides of the table, maybe hit another ball that hits another ball that hits the ball you want to hit, and it's all kind of complicated. And I think that's a nice metaphor for kind of the situation that we're in when it comes to alcohol and alcohol-related health disparities. We're in a pretty tight spot, but we can work together and use each other to maneuver around the 8 ball and to eventually get to where we want to be. Thank you very much for being here and listening to me while I wave my hands around.
Thank you so much. That was amazing. I learned a lot. We have some time for questions, and we have folks floating around the room with microphones. So if you want to raise your hand, get started. I don't see any hands, so oh, we have a hand over here. And Dr. Wong as well. So I'm going to let you.
Okay.
Hello. Oh, okay. So I had a question regarding, because I know we talked a little bit about alcohol policies, and I just had a question if you feel like sometimes alcohol policies can be double-edged in terms of like maybe creating policies that may, yes, lower consumption of alcohol, but maybe reduce criminalization of certain already marginalized communities. When we think about like how will these policies be enforced and who will they be enforced on more? So I just had a kind of a question around that as well.
Yeah, that's a great question, because anytime we want to implement any kind of policy, we need to consider if it's going to affect different populations differently, because oftentimes it will. Regarding criminalization, so I'm trying to think of an example of one that would do that. I mean, so anything that's going to be enforced by police departments is going to be potentially subject to biases against communities of color, right? Like we know that. So that could be one. So I think it depends on what the policy is and who you are empowering to do the enforcement. Is it a group like the police? Is it community members or community-based organizations that, for example, there are some policies where liquor stores will be held to account, not exactly dram shop liability laws like Dr. Chung was talking about earlier, but if they see minors buying alcohol in these places, they will be held to account. And I'm blanking on the example, but one community did this, but it wasn't the police who were responsible, it was a community organization that was responsible for calling out the liquor store for doing that. So in that way, so I think it is definitely possible, and that's why we have to ask that question anytime we want to implement a new policy. Yeah, great question.
Thanks, Dr. Martinez. Great presentation. In recent years, I've seen some social media promoting an abstinence month from alcohol. I think it's called, what, Dry January or something like that. Do you have any comments about whether those activities have been effective in terms of mitigating alcohol misuse or having any impact in terms of just people's consciousness about the deleterious use of alcohol? And secondly, is that campaign not penetrating minoritized communities?
Great questions. Okay, yeah. So we have Dry January and Sober October. It is kind of funny, isn't it? How many people have heard of Dry January? Okay, so most of us. How many people have heard of Sober October? Yeah, Sober October is a little bit less well-known. Okay. We know that there are some benefits from abstention for Dry January for more acute alcohol effects. So people report, this isn't rocket science. People report fewer hangovers and they report kind of sleeping better and feeling better overall. So there are those more short-term effects that we see. Long-term effects haven't really been studied. So I couldn't make a comment. Although, 90% of people who use alcohol don't have an alcohol use disorder. And if you're able to abstain completely for a month, the likelihood that you would develop an alcohol use disorder might be low. So there might be a little bit of selection bias there in who is just agreeing to participate in these sober months at all. And then your second question was about whether or not these awareness campaigns penetrate into minoritized communities. So which campaigns, like you talked about Drink Less for Your Breasts or like the Dry January? Oh, those. I don't know of any data looking at that. That's a great research question. Maybe I'll write a grant about that. Yeah, I don't think we know the answer. I think, somebody correct me if they know, but I thought Dry January started in the UK and then kind of via social media came over here. So I don't know about participation in Dry January by racial and ethnic group or by level of education. I don't know. That's a great question. We should learn that.
So one of the things I was thinking about was in regards to policy efforts, just like tobacco, when they raised their age limit to 21 from 18, they put in the language that they could not go after 18 and under consumers of tobacco products. And then what they do is penalize the retailer more. So if we were to develop more policy efforts that would focus on putting pressure and putting tax dollars or bills or financing fees to those agencies, we can have a little bit better control of what's going on.
Totally agree. Yeah. Make that happen. I'm just kidding.
Hi, thank you for your presentation. I really appreciate how you brought up how the social consequences and the inequities and how marketing affects and the links between alcohol use and domestic violence. And I appreciate what you said about community-led solutions. And I know that domestic violence is a complicated topic and it's a sensitive topic, but I wanted to see if you've seen or heard of community-led solutions that try to address that and alcohol together, and try to maybe reach people who cause harm and who may be struggling with alcohol and try to kind of integrate those two issues together, because sometimes they're, I feel like, talked about separately, even if they are related?
So, yeah, I don't know of studies that have looked at domestic violence as an outcome, but I know they must be out there. So really, that would mean lowering the likelihood that somebody who would enact violence has access to alcohol or has situations where it's okay to drink enough where they would go home and do that. So I would think that policies that reduce, so when we talk about the reason we like broad policies to reduce harms is because it includes all harms. So I think you would see a decrease in rates of domestic violence if you had a lower alcohol outlet density, or if you reduce, actually, no, that study, the outcome wasn't domestic violence. A recent, like this is just published by a colleague, looked at, so Maryland recently reduced the number of, I think it was off-premise outlets available, but they looked at violent crime. I think overall, they didn't look specifically at domestic violence, but they found a decrease. So I think if they were to parse it out, you probably would see a decrease in it. And I think we need to think big when we think about policies. There are all these outcomes, individual outcomes that are really important, but if we have policies that are going to affect all of them, we should do that. Because otherwise it gets a little bit piecemeal. And that is kind of more work for less bang.
All right, so please join me in thanking Dr. Martinez. It's a really great talk. I'm going to pass it over to Dr. Fola-May. She's going to introduce our next speaker.
Good afternoon. It's wonderful to see everyone. I have the honor of introducing our next presenter, Raul Verdugo, who will be speaking to us on policy, advocacy, and organizing in 2024 with a special focus on the post-COVID era. So I'll tell you a little bit about Raul Verdugo before we get started. So you can sit for a moment. As Director of Advocacy, he's the Director of Advocacy at Alcohol Justice. And as Director of Advocacy, he oversees the advocacy program work involving the Los Angeles Drug and Alcohol Policy Alliance, or LADAPA, and the California Alcohol Policy Alliance, CAPA. His outreach efforts and interests have expanded his work to Native Indigenous communities in California and in other states. His value of communication, engagement, and inclusion, including a passion for art and creativity, guide his efforts in aligning partnerships and working collaboratively to pursue change. We're very pleased to have you here today. Please come to the microphone. Thank you very much.
Forward. So actually a little bit forward. Very beginning. Here we go. Okay, great. Hi, good afternoon. Great, it's nice to be here. I'm just gonna get started. Wait a minute. Okay, great. Is COVID truly over? Associate Professor of Epidemiology, Dr. William Hanage, reminds us that vulnerable populations are still at risk, as are people in healthcare institutions. Though we're not likely ever to return to where we were before COVID, boosters will help in addition to the steps we take to reduce transmission. If we. Okay. Oh, okay. Whoa. Okay. Though we're not likely ever to return to where we were before COVID, boosters will help in addition to the steps we take to reduce transmission if we find ourselves symptomatic. What were the lessons of COVID for us in the nonprofit sector? To be quite honest, it was hard to assess and pretty far from my mind at the time. I was largely focused on the work we were trying to do and all the various shifts taking place. I had a lot of anxiety as to what the future would hold and what we would look like coming out of COVID. I'm Raul Verdugo, Director of Advocacy at Alcohol Justice. Our mission is to prevent the proliferation of misuse of alcohol and other related drugs and reduce the harms associated with populations targeted by the alcohol industry through evidence-informed advocacy and community organizing. We operate 2 projects comprised of organizational member support, the statewide alliance CAPA, and our local alliance LADAPA. In San Rafael, located in the county of Marin, we operate a youth program by the name of Youth for Justice. Without getting into the depths of what we do, essentially we advocate through policy. I'd like to begin with where things were in the summer of 2020. Many states throughout the country grappled with the idea of alcohol, and California, was no different. We are the largest producers of it in the country, and at the time it was deemed essential in California. The California Department of Alcoholic Beverage Control provided special permits allowing cocktails to go and alcohol delivery to occur. And then we were faced with COVID happy hours and quarantinis to offset the anxiety and boredom of what were lockdown conditions that had begun. Now, as both an agency and in our alliance work, this impacted our messaging and the ways we'd address alcohol at the community level and among policymakers. Outlet density, access and availability, overconcentration of licensing, and alcohol deregulation have been our assessments as to why problems exist with alcohol among community and throughout the state. Suddenly, we found ourselves in a situation where our advocacy could no longer be seen not as part of a solution, but more so as part of a problem. How would we position ourselves on the issue of deregulation? But we were committed to do our part in the wake of a worsening pandemic. The science hadn't changed, but its validity had become questionable. The worst of what we feared wouldn't be made clear for a few years, but it did eventually come. A year before, in 2019, at the local level, we were running a campaign to pass an ordinance in the city of LA, pushing the effort to try and mitigate the foreseeable harm associated with increased access to alcohol and alcohol outlet density. We were highlighting the science correlating crime to density. It was a 2-year motion that would eventually be held up long enough to expire in January of 2020. Shortly after that, I had the privilege of a meeting with Dr. Randall Henry, founder and chief intelligence officer of Community Intelligence. He's authored 3 books and co-authored a children's book. He's a resident advocate and a staunch supporter of South LA. It was during this conversation, he asked a very profound question. If your campaign was adopted, motion made an ordinance today, how would that improve my community tomorrow? I couldn't provide a good answer to the question because I hadn't been prepped for it. But I was grateful for the question because it was at that moment it made me realize that maybe we collectively didn't quite understand the problems we were trying to address in the ways we should have. Not that long after that, we had a meeting with community members in South Los Angeles at a neighborhood council meeting discussing crime and density. They didn't agree with our conclusions. They made it very clear that liquor stores in their areas were not points of conflict with crime and violence taking place, but more so as a means to employment. access to food, and other basic household needs. We realized during COVID that although some communities were similar in the needs that were not being met, many fundamentally lacked information, opportunity, and resources. Internally, as an agency, and among our alliances, we were undergoing shifts, major shifts in personnel. Within those dynamics, as a local alliance, we were assessing our next campaign effort and the stories of corruption taking place in City Hall with the recent indictments of former council members Mitch Englander and Jose Huizar. We launched a local campaign to begin offering ourselves as a resource to communities and families struggling through COVID, like many others were across the country. But what we were determined to figure out was how we could meet the underlying needs of community based upon the issues being raised across the nation with homicides of George Floyd, Ahmaud Arbery, and Breonna Taylor. How could we begin to bridge the divide with the work being done to address addiction, childhood trauma, spousal abuse, violence against women, law enforcement, incarceration, and alcohol? How do they correlate? How did the issues of redlining in Los Angeles then again play a part in the root cause of overconcentration, and community? COVID in many ways helped us begin evaluating our approach with the issues we were seeking to address with alcohol and the methods we were taking to address the various community needs as they relate to alcohol. How could we truly begin to partner with members and agencies in a meaningful way to reduce alcohol-related harm? Amidst all that, we were forced to face the fundamental issues that COVID exposed on the other side of the spectrum. How would we begin keeping pace with a virtual world? How many people remember their attempts at hosting their first virtual meeting? From a technological standpoint, we were behind, and we're trying to pivot ourselves to meet the challenges and changing conditions we were forced to adopt. It became clear to me, though, as a nonprofit with our alliance work, we had to begin pushing our product and developing it as though we were operating a for-profit company with a product to sell. How well vested were we in understanding social media? How informed were we in understanding metrics? Were we really that effective in utilizing a DIY approach to developing our own content and maintaining our own websites? At the core of what we do, we are trying to reach people. In the nonprofit sector, we are trying to elicit a response, to engage community with our coalitions, community events, and fundraising. We're trying to build awareness to who we are and what we do as agencies. For-profit companies have goals and objectives. They think not only of where they are, but where they want to be. They must be adaptive, recognize trends, and consider politics at both the state and federal levels. In 2023, this article emerged, looking forward at very similar issues, and these were challenges they identified. And, excuse me. Oh, excuse me. There we go. And these are the results of their findings. What we did as part of our alliance work in the past was to provide an experience. We introduced policy as advocacy with the hopes of incorporating people with a sense of knowledge and empowerment. But what we wanted had to be much more than a visceral experience, and yet it wasn't. So COVID helped us to realize that our work had to become regenerative. As an alliance, we must evolve as an asset to our members as they in turn become an asset to their communities. We need to invest in our product, invest in our membership with the knowledge and experience needed not simply to feel empowered, but to become empowered. And in so doing, have that knowledge transcend itself into community. Engagement is at the cornerstone of our work, and how we go about doing that become our determinants in how we move the needle and the future of our work forward. Thanks.
We have time for questions. Can you hear me now? Oh. Questions from the audience? We do have time for questions. I'll start with one. Thank you very much for that presentation. And I think I, was interested in many parts, but one of the things that stuck with me was the idea of empowerment, because I think in a lot of what I do in cancer screening, it's about empowering patients, empowering individuals. I was hoping you could share with us a little bit more about how you feel that we as physicians, as researchers, as organizational leaders can empower community organizations in this advocacy work.
Well, first and fundamental, I mean, empowerment really, I think centers itself around knowledge. And so what we've done is we've incorporated knowledge and data sets into the work that we look at to address alcohol policy. And if you're trying to engage community, it does come from a sense of knowledge that really, I think, is really critical to how they emerge as empowered individuals. If we're not taking time to understand not only what their needs are, we can't really begin the process of empowerment, because empowerment comes from different angles and different perspectives. And sometimes the needs aren't really as clearly laid out as we would think from one community to the other, as we found in our experience. And so from a larger standpoint, I think the more we can talk and have discussions with community, assess what their needs are based upon how they're interacting with alcohol and what their communities are facing, we'll find that that empowerment then begins to take hold. But we have to break down their individual needs and not what we come to believe as standardized reasons for why people engage with alcohol and why they have problems in their community around alcohol. From a clinical standpoint, there is enough information out there to make us begin to think we understand the issues that many face, but until we actually get there and talk to them, it might not very well be those immediate issues that they're facing at that moment. So like with that example with South LA, I mean, that was clearly something that we had kind of missed the mark on, because we came into a community with knowledge and information we thought would be beneficial to what their needs might be in our assessment. But what we realized was that we kind of looked beyond what was there to imagine that we understood what it's like to live in a community where you have very little access and resource. And so the way we began to empower people is to put ourselves at the level by which they live a daily life, to begin to understand where we can start plugging into making them empowered. Is it enough just to get them to recognize an issue, or start to address the underlying issues of why they're driven to alcohol?
Thank you very much. Other questions from the audience? Else? Over here. Thank you. Oh, sorry, no, I wasn't. We do have a question in the corner.
I'm curious to go back to the slide about regenerative ideas. I like that term a lot. And I guess in the sense of like empowerment, advocacy work, how, and not just generally in alcohol, I think across all, schemes of public health, how do you make public health and advocacy work regenerative? How do you continue the work past, just the initial grant that you received to do that work? And how do you ensure that the community is able to actually gain from that long term, and really see like a follow through of the ideas and, information you're trying to share with those communities long term?
That's a great question. When I thought of the word regenerative, it wasn't really something that I put a lot of effort behind trying to apply to a broad scope of understanding about an issue. What I really started to look at is what weren't we doing as an alliance to ensure some of what you mentioned, which is if someone steps away, if someone moves on, because we were feeling that and seeing that as personnel, how would we continue the work that was established? And understanding that without taking deliberate actions to either train, create workshops, things that people could take from an experience of learning and turn that into something they could actually take part in, and then understand how to then take it on themselves, we weren't really facilitating ourselves with our efforts too much. It would end literally if someone walked away. And then the idea of regenerative, when I started looking a little bit deeper into it, it actually is a philosophy that emerged right around 2021 to talk about that very same issues. How do companies, how do businesses, how do people begin to entertain the idea of what they do as a regenerative process for generations to follow? And when thinking that way, they find that it lends to the capability of being more productive because you're taking those immediate steps to try and engage those coming into the new fold of like whatever industry you're dealing with, if it's clinical, if through prevention, as these new people come in with what you've done before, if you can leave, I wouldn't say breadcrumbs, but like a path by which they can repeat, then it benefits community in the long term because it revolves around a continuum. And so part of what we wanted to do, and we realized and recognized we had to start doing, was invest in the people that we're working with to ensure that as young people, because most of them typically are, they will learn what needs to be done so they can then take those steps and move them further along. The work we do and through policy and through alliance work that we come to this discussion with is only part of a longer and larger effort and a process. We identify where we pick a part in that process and then try to really enhance that opportunity because there's other people here doing different kind of work that also feeds into a process of what we eventually want to stop. We have to recognize what roles we play and how we can continue the work as time moves on, situations emerge, and pandemic-like situations take place. How do we continue that? We were kind of like, we weren't really strapped without being able to go and meet people in community. We were really like thinking, how are we going to reach people? And so when we think about all these aspects of what tools we have, that's when the idea of like not being maybe fundamentally sound in technology was a real setback in our work because we were kind of behind the 8 ball on what most of the industries were already doing 2 years prior. And we had to make up for lost ground and then figure how can we be where we need to be in community and access them and then in turn access us. So thinking regeneratively would then mean what steps can I take to ensure that what I'm doing will have follow through as I move on? Because we all move on in our careers and we might move from one agency to another, but what steps have we invested in our coalitions, in our community groups to ensure that the next people coming also can continue the work? And that was part of the bigger picture.
Oh, another question right here.
So you mentioned earlier that when you were asked how would this impact my community tomorrow, you didn't really know how to answer in the moment. So how would you answer that question now?
Well, it really comes down to assessing this, like survey assessments really, I think are the only ways in which we can really get to starting to unravel and start to dissect what communities need. And if we're not taking those active steps, it becomes almost as if when we do get, and this came up during that conversation, it was like, as if we do get support for that moment, does it then become transactional? Because we managed to maybe come up with a line, pitch a point of interest that someone can move towards, but I don't really know their story. I don't really know what they're struggling with. And so in order for us to get to those depths of understanding, we have to start to imagine what these conditions look like in their communities and recognize that it may not be across the board the same. And there's no real fault in that. I mean, access outlet density and increased in consumption and so forth are really bad conditions in most communities. But likewise, I grew up in communities where liquor stores weren't more abundant than most supermarkets would be. And so, I mean, I went to liquor stores pretty frequently, but I never purchased alcohol. I bought my first cap gun as a child from a liquor store and I bought like treats and things like that, but I never had an issue with alcohol. I never saw what's being talked about in the studies face to face, but I lived in an area that was predominant. So I think it's different for everyone and we have to begin to have these conversations with community and understand how do they see the issue? And really what we come to understand is that, you know, if we don't provide resources, alcohol is like an ends to a means. An ends to a means. It's just like an extension of something underlying that's promoting that, that's forcing people into that. If we don't start to break down what those underlying issues are, we can deal with alcohol, but they might find another way to repeat an addiction, something else. And we got to have those understandings to say, and how those forms to say, like, how is alcohol impacting your community? Where do you see a problem with alcohol? Is it youth consumption? Is it domestic violence? And how are we coordinating with people doing that kind of work to understand where we can be helpful to the process? I mean, I met someone doing domestic violence work and she told like horrific stories and really engaging and compelling because you could not even imagine the depths to what goes on in households dealing with domestic violence. It's really quite astonishing. But nevertheless, we weren't working together to pass any legislation, draft any bills, look at anything that would provide more resource to that end, because there are correlations to alcohol, and we would benefit from that. As the former speaker talked about widespread policy, unless we begin to understand what they're doing and how we can be a part of it, we won't see those changes taking place.
Another question over here. Give me a second to get to you.
Good afternoon. This is really a basic question. Have you found that really when talking to individuals that the alcoholism is for more one, just pure boredom, not knowing what to do with their time? That's one. And two, are they also associated with people that really feel they don't have an outcome, a vision, or a dream, something of like they're working towards? Have you run across that? Because we're talking about policy and everything, like what about the being? You
The
know,
what?
it actually, the being in us and ourselves, accountability to us, or something that we're lacking inside.
Yeah, I
pass
think that
time
really,
away.
yeah, when people talked about like, cause I read articles and people talked about it in media and stuff, people were fundamentally bored. And we think about those people as having no real problems, just trying to entertain themselves in lockdown conditions. But I think when people start to really break down, what is it that moves people to drink, and there aren't really significant problems, we then have to figure out how do we start to reach those people to think, are there other outlets? I mean, it doesn't always mean that because people drink, they're going to have problems, and because people choose to drink, that they're out of control. There are ways to integrate that into their lives and live fulfilling and fruitful lives, even with alcohol. But what I think it really comes down to is how we can begin to message what we want to say in the right kind of way to the right kind of people if we choose to move a particular viewpoint across like a social media spectrum and or printed information, so that people begin to understand that this is an issue that affects people on a whole host of across the spectrum, I should say, in a whole host of ways. And for basic individuals who have issues with alcohol, we always try to not really look at the fact that there's going to be an immediate underlying problem, but where we can best maybe step in to offer solutions as to where they can get help if they're interested in getting help, or finding ways to alternatively think about alcohol. I mean, right now with mocktails emerging as they have been, there's been a real definitive idea in mind that young people are coming into alcohol, but not in the same ways they were introduced to it. And that some of the COVID findings really made young people start to think, I don't want my lives becoming what I saw emerging from COVID. So I'm going to turn to something alternatively. And within that study, it was actually part of a conversation. They actually had said, well, we're not really giving up alcohol. We're just kind of balancing our lives with the idea that we don't have to drink to such a large extent in order to feel what we want to feel. And our lives don't have to be so interlocked and intertwined to this idea that we are somehow linked into alcohol as an identity of who we are. I think that tends to happen with a lot of individuals growing in this kind of society that we live in, that oftentimes searching for a sense of self, they might find it through alcohol as a means to say, I'm connected, I have friends, I can be social, rather than thinking I can find other alternatives to do that. And interestingly, in that particular report, the woman who they interviewed was very young, and she said, my mom actually drank, but I wanted to be amongst people, and I was always kind of withdrawn, so I began to drink. And she liked her life outside of alcohol and realized her closest friends were not people that she drank with. They were people that she grew up with who were not involved in alcohol. So the perception by which we come into contact with alcohol, I think really starts to affect how we engage with it and what we're using it for, essentially.
Thank you very much. I'd like to give a round of applause to Mr. Verdugo. Thank you.
Thank you.
Thank you. So we are setting up for an activity, as you can see, the little rejuvenation before our expert panel in the afternoon. So if you just bear with us, it should be a couple minutes and we'll get started here. Thank you.
Sí, hasta que ellos digan.
Okay, hello everyone. Good afternoon. Now we're back to getting started. So it's my pleasure to present Veronica Romero. Veronica Romero works as a health and social wellness mobile food pantry coordinator and outreach for the Fernandeño Tataviam Band of Mission Indians. But Veronica is also a sound bath healer who uses rattles, drums, bells, and Tibetan instruments to relax the body to its highest state. She's done coursework in magnetic energy, has completed Reiki levels 1, 2, and 3, and is certified in Aroma Touch and doTERRA oils. Her most cherished blessing is the discovery of this journey of spirituality as a mujer medicina, or medicine woman, for nearly 7 years, which brings her peace, harmony, and love. I had the privilege of experiencing Veronica's sound bath experience at a Leukemia and Lymphoma Society event. And so I'm very thrilled that you'll be able to experience this as well. So please join me in welcoming Veronica and her team.
And I have the pleasure to announce that with me, I have Irma Larios right here to my left, and on my right, I have Miguel Lara. I didn't want to ruin that for him. And they are alongside with me with this journey, and they do everything I do and more. And I'm so blessed to have them in my life, and I'm blessed to be here today. I'm very thrilled to be here, and I'm glad that we'll be able to provide this infusion of sounds for you. And if you would like, when we are doing it, when we're playing the sounds, if you would like to close your eyes to really feel more of the infusion of sounds and what it does for you. Well, thank you. And if you would like, you can place your hands on the center of your stomach, your solar plexus.
Okay, join me in thanking Veronica and her team. Thank you, that was wonderful. And then we'll let them clean up a bit and then we'll resume. Just give us a moment.
Tell them if they have any questions or anything. They can like sign up outside. And also their sage. Send them would you like to say that again? Yeah. And then we'll start. There's a sign-up sheet right outside on the snack bar. If you have any questions or anything that came up for you, you can sign up, put your email or number, and we'll follow up. Also, there's sage next to the sign-in sheet, and that sage is from the lands of the Fernandino, Tataya, and Bana Mission Indians from the Simi Valley Mountains, and it is blessed by the elders. The elders help wrap some of that sage, and we were in union together and working on the sage. So you're welcome to get some. You're welcome.
On this side over here, or?
Yeah, just like in a semicircle. No.
Oh, okay. Oh my God.
talk show.
Yeah.
Oh, take our pick?
I do not know about. These two. This one works. Does that one work?
Hello? Yeah.
Yeah,
This one works?
yeah, they all work.
Okay. Here you go, Richard.
And then.
Yeah, you can do anything you want.
Audience members?
Richard.
This one or?
Whatever. Shut that off.
Okay.
Battery.
Okay, if I bring my chair back, so I can.
Anything you want. As long as the audience can get it.
We need to.
How much time should we have for Q&A?
Hi, Rick Feldman. Glad to meet you. Thank you for the invitation.
Okay.
Hello, everyone. Okay, so we've had a wonderful day and we have a really, really interesting panel coming up. It's going to be moderated by Dr. Winston Wong. And I will tell you a little bit about Dr. Wong before he takes over. So we're very privileged at UCLA to have Dr. Wong as a scholar in residence at our UCLA Kaiser Permanente Center for Health Equity. He has had a 30+ year career increasing health equity and addressing racial and ethnic and socioeconomic disparities. He's got so many awards and titles, I can't go through all of them, but just a few. For 17 years, he was at Kaiser Permanente, and he was the medical director of community benefit at the national level, tasked with developing community partnerships to address health equity. And we worked together during that time. He is currently the chair and acting CEO of the National Council of Asian Pacific Islander Physicians. As you might have guessed, he's a physician himself from UCSF, our rival. He's also been chair of the U.S. Department of Health and Human Services Advisory Committee on Minority Health. And he's currently the chair of the Roundtable on Health Equity for the very, very prestigious National Academy of Medicine. And I have to talk about this award. He had the Outstanding Service Medal from the U.S. Public Health Service. Dr. Wong.
Thanks, Roshan. That was very kind of you, if this works. Hear me?
You have to turn it on.
Testing? Yeah. Hello, everybody. And thank you, Roshan, for those nice words. I want to congratulate all of you because you've made it to what I know in Los Angeles is kind of the witching hour. There's two things. I'm from Northern California. I'm from San Francisco, okay? And I've come here to Los Angeles quite a bit, as certainly as honored to be a scholar in residence at the Center for Health Equity. But I know there's two kind of like, dare say, guttural responses in Los Angeles. One is when it rains. People in Los Angeles go kind of semi-crazy. It's raining, and they dash around. And another thing is around 3:30 to 4 p.m. It's kind of like, uh-oh. But we'll get you out by 4 p.m. and your car will not turn into a pumpkin. I promise that. I also want to take the prerogative of thanking the cultural artists that you invited today at the center. I think they were fantastic. So let's hear a round of applause for them as well. And during this course of this last hour of this great day, if you feel like just standing up and stretching, feel free to do so. It's good for your health because we're not offering any alcohol beverages. It's good for your health to stand up. So we have a great last session because I took a look at the room. Everyone was really anxious to hear about what's happening in Los Angeles and in Southern California in terms of community action relative to alcohol use, what our community partners are all about, how we build collaboration across community advocates and the people that we know that have the wisdom within our communities. So we do have 3 individuals that will share some of their stories, and we will have time for you to ask questions. And what I'm going to also do is if you can think of those questions right now, even before you hear our speakers, because I'm going to try to channel you to hear what you're sending forward to us to be able to engage in conversation with these great individuals. So I want to, in your packet, I believe you have a description of each of our individuals here, Richard Zaldivar, Cruz Avila, and Sandy Logan. We don't need to reread the biography, but we do need them to share with us kind of what really is kind of the challenge is for you to do this in about 2 minutes, okay? So in 2 minutes, 3 minutes maybe, because Richard has a kind face, can you tell us a little bit about what's special about your organization, something that we wouldn't know just by reading the biography and the cultural, the organizational description that's in the packet. Tell us a little bit about your community, your organization, and really what's special about it, Richard. Let it warm up a little bit, maybe. Yeah, you got it.
Takes a while to go up. Richard Zaldivar, I'm the executive director and the founder of the Wall Las Memorias. Thank you so much, Winston, and thank you, UCLA, for the invitation. I just want to say, I'm a temporary student at UCLA right now as I'm taking the board certification class, and it's really kicking my butt. But anyway, I also want to say, because we're in her room, it's nice to be back into this room and see Be Strong. Beatriz Solis was a good friend and a mentor to me. She's a sister of Supervisor Hilda Solis. She passed away a few years from cancer, so it's great to be here. I am the founder of an organization when people were dying of HIV/AIDS, and there was very little work, very little support for my Latino community around the LGBTQ issue. And so I'm also a recovering alcoholic. And being a recovering alcoholic of 35 years, back then I learned what was going on in my community, and I decided to envision a memorial to people who died from AIDS, for a place where they could remember those who passed away, but more so to empower the community to address the stigma and the denial around HIV. And so my organization today is awesome. I love it. We just celebrated our 30th anniversary. And yeah. And we do a lot of work around HIV prevention and testing and PrEP services, but we also do work in substance use prevention and mental health prevention to the Latino and the LGBTQ community. A lot of other work around cancer research. We're working with UCLA on a grant right now around cancer. So we do a lot of great work, but the thing that's so unique about our organization is although we do programs and services, we organize communities to address the issues that in front of us that are needed to be addressed. And so last night we were just at San Gabriel City Council because there was a report. They wanted to form an LGBTQ outreach program and the city council shot it down. And we organized a group to be out there until like 11 o'clock at night. So that's just an overview, a little overview of what we do.
It's a great story. Tell us something special that none of us would know just by that description, something insider tidbit about the wall and your organization.
I like to see that my organization, because of all the great people that work for me.
Yeah.
It's a spiritual journey and they're all passionate about the work that we do. And we see health. We look at health not only or social justice, not as only as social justice, but we see the intersection of social justice and health justice. And we're building a new generation of leaders. That's what I really love doing.
Yeah, that's great. Thank you, Richard. Next, we're going to go to Cruz Vila. And Richard really modeled for you that he did this in about 2 or 3 minutes. So I'm looking to you, Cruz.
So thank you. And once again, I think it's truly blessed to be able to be here today. And I'm a firm believer in fate. I always want to start off with that because God has a very unique way of connecting folks across the board. And the fact that I get to be up here next to Richard, next to Sandy, we work very closely together on a day-to-day basis, but having Richard as my previous board chair as well, and learning from Richard, and as our organization, Alcohol Justice, I always like to ask that question, who has heard of Alcohol Justice? Raise your hand. So this is the true purpose of why I believe God put me in this position. Started off with Friday Night Live in Fresno County, born and raised, and full circle now coming to Alcohol Justice 20 plus years later to be able to continue to run an organization that is based in Marin County, but we're statewide. So our organization is out in Marin County in San Rafael. So we're out there with the goal to really help. And I always write this down because I want folks to truly understand what Alcohol Justice does, is to build healthy environments that empower communities that are affected by the negative impacts of alcohol and other drugs. And so there's many ways that we do this, but through our work, and Richard said it so elegantly, is that it's the team that you build and the family that I work with. And I've heard this go back and forth that you shouldn't call your organization family and you can't put that label. But at the end of the day, when you build a true working environment that you can look at your next door neighbor, your community member as a family, that helps truly build the community that you want to live in. And so I'll end it with that.
That's a great message, Cruz. And, you know, you mentioned the whole connotation of family, which I think we all feel it's very culturally defined. And in a very pure European perspective or Western perspective, it might have less of a dimension than what you're trying to describe. I'm really curious about the organization's name, Alcohol Justice. Can you give us a little bit of perspective of how that name came about and what that represents for you?
So interestingly enough, so we started off as the Marine Institute back in 1987. So this organization has been around since 1987. And it wasn't until 2006 that it transitioned into Alcohol Justice with my previous predecessor. So when I started with this organization in September of 2021, right after COVID, it was interesting to see why they changed the name from Marin Institute to Alcohol Justice. And the response from my predecessor was because they were really trying to have folks understand the legislative level, when we testify at the state level up in Sacramento, truly what alcohol justice is supposed to be defined as, what it's supposed to truly mean. So my predecessor said that they stuck with alcohol justice because alcohol justice is what they're trying to provide, alcohol justice. But we just finished our strategic plan, the 3 to 5 year strategic plan, which Richard was a vital part of that process. And a major part of that process is that when folks look at our alcohol justice, though, they take a different tone because they think we're actually supporting folks to drink, which is interesting, right? So, but that also brings a conversation point to be able to ask, what is alcohol justice? What do you guys do? So that also helps that elevator speech that we've continued to provide with folks to really have them understand, educate, communicate the effects of alcohol and ATOD, which is alcohol, tobacco, and other drugs. So it starts that conversation process. I will say, though, that we're in the elements of looking at perhaps redesigning and maybe perhaps switching that title, so that more information to come on that as we go through our process. But that's what I can give you on the alcohol justice, because I stepped into that process after the fact, but we're navigating through that as well.
Yeah, I hope we can hear the elevator speech a little bit later too. We'll get some
Sure.
tips. Next, we have Miss Sandy Logan. Miss Sandy Logan of Pueblo y Salud. Sandy, do you want to give us a little bit of a description of your organization and what it's up to?
Yeah, so Pueblo y Salud was established in 1991, and we're really focusing on community health. So Pueblo is community and health, Salud is health. And we really work on grassroots organizing our community on, especially we do have a substance abuse prevention contract, but we really work on policy work and trying to bring in the community to be the voice for what the change that needs to be happening in the community.
Sandy, can you tell us a little bit about your geographic area of concentration and what kind of programs you offer in that area?
So we really focus on the Hispanic community.
Yeah.
We do have the majority of the San Fernando Valley in the Northeast San Fernando Valley is the majority is Hispanic. So really working with our Spanish only population, encouraging conversation, showing them how to navigate the system and to make their voice heard. A lot of the services that we offer are prevention. So we offer like life skills in the schools. We also work with the parents on how to understand the conversation about substance abuse, but even just how to start that conversation. And then once we get them involved in that part, then we can work towards policy.
And how long have you been with the organization, Sandy?
For about 3 years now.
Okay. So in those 3 years, I'm sure you've kind of identified, the question here I have is challenges and issues, but I want to ask you not just about challenges and issues, but the assets in your community with regards to addressing issues around alcohol use.
I think the biggest asset is that personal relationship that we develop with families. And what I mean by that is by meeting them where they're at, understanding what their needs are, if we need to have a food drive, or look at like health insurance and help go through that process. Once we are able to serve them in outside the prevention aspect, we're able to gain that conversation and to help them understand help them understand what is impacting them and what they can do about it.
Can you tell us a little bit how you have these conversations? Is it in the course of doing case management or, outreach activities, education events? how are you able to gather the voices of your community in terms of identifying not just what their needs are, but what they can bring to address those needs?
Everything from community meetings, everything from educational courses. We've even gone out and knocking on doors. One of the recent policies that we passed was secondhand smoke in apartment buildings, condos and townhomes. And we were able to pass that policy during COVID, during the time when we were not able to leave our homes. We wanted to make sure that the community had a voice to be able to vocalize that secondhand smoke was coming in and affecting their quality of life. So we went knocking on doors. We asked for videos, sharing their testimonies of what was happening in their home, and then brought it to City Council.
And what city council was that?
San Fernando.
Oh, great. Really interesting stories. Cruz, I have that kind of question as well. I mean, I'm sure you can identify what the challenges are, but I'm really also interested in terms of what you've been able to build upon that is part of your community innately.
You know, so for us, it's that humanistic approach that we continue to now take. And I say the humanistic approach because where we're based in San Rafael, it's called the Canal. And the canal is located right off of the 101 South, about, I want to say, probably about 2 miles away from the Bay Bridge, going towards San Francisco. But in this community, when I first started in 2021, 15,000 residents, but within that time frame to now, it's about 18,000 residents. And so when you look at that level of increase that is low to moderate to very low income, affordable units, the geographic area that it sits in, and the humbleness of the folks that we are littering the backyard of, it's the connection with the community that that represents who we are, but also that we as an organization are the safe haven for a lot of these students, a lot of the families that don't necessarily have the education, the means to be able to know what true resources are out there when their youth are going through the portions and the day-to-day of pushing to drink, taking a certain type of drug, looking at all these elements that they're having to deal with. That's where alcohol justice has come in to really help navigate and then give those families that information that they're looking for. So we've almost become like a therapeutical organization when it comes to families of where we're located. And obviously with that comes the information when we're potentially working with legislation on these bills, anything that's coming in within the sector of what we're doing on a day-to-day basis with the advocacy work statewide, with the legislative work statewide. So we're constantly being able to mentor a lot of the youth, a lot of the families, the adults, even the seniors that we connect with on a day-to-day basis to educate folks so they have that better understanding of the do's and don'ts of what makes a community thrive versus not thrive as a whole.
So it's interesting that you're based in Marin. And Marin, its reputation would suggest it's one of the wealthiest communities, not just in California, but in the entire country.
Exactly.
Can you elaborate on whether that's a challenge or an asset or a specific ordeal that you have to deal with from alcohol justice perspective?
You know, it's unfortunate because it's the fact that that's what comes up in a lot of these city council meetings as well when we're talking about the problems, unfortunately the continued intoxications that continue to take place within the canal. and the local high schools and the lack of community resource centers that are around. So it's really disappointing at times when you look at how the canal is labeled within the county of Marin and San Rafael as a whole, and seeing which this really gets me, but just seeing the way that folks address folks of perhaps a different color of skin, what kind of car you drive, the kind of clothing that you wear. And a lot of these families that we represent within the canal and that we are providing services to, you wouldn't think alcohol justice would do that, right? Because of the policy work that we do, the type of services or programs that we have statewide. But the form and the correlation of how alcohol justice became and how we are a recipient of a trust that provides the resources and the financial support to our organization was due to our trust holder who believed in the alcohol education to really help youth understand and have a better light of what the effects truly are, and as you grow, how those continue to affect you. And I only give that longer response because and as bad as this sounds, but it's the reality, and I'm always going to be very transparent, but always very professional at the same time. The canal is seen as an eyesore in the city of San Rafael because of where it's at, the families. And so these are the stigmas and the type of unfortunate conversations that we have to continue to have and that we're still having is a disappointing piece of how we're still living in a world where you're judged by what you drive, what you wear, and how much your house and your income, the household income makes, whether to be respected or to be seen less of. And unfortunately, alcohol surrounds a lot of that the therapeutical part of it, that a lot of the families that we serve and that we represent within the canal, their therapy would be considered a 40, an alcoholic drink, right? A beer, versus knowing that they can go to a counselor, but then also that's the culture. Some parents don't want to be going and seeing a therapist, so they take care of their therapeutical sessions by drinking. So these are all these surrounding issues that make it the humanistic part of how we interact with our community.
Yes, we can talk a long time, Chris. You have some really interesting perspectives because coming from just across the Golden Gate Bridge from where I'm from, I had never heard of the term the canal. And the canal, I don't think, is designated as a city or but it's a living part of the community that is starting to define itself by its sense of justice in the face of white supremacy and the class differences that occur in Marin County, from what I hear.
Yeah.
Amazing story, and thank you for sharing that. So, Richard, you started off talking about your 30 years of advocacy around HIV education and outreach, but how this intertwines as well with alcohol education and outreach. Can you talk again about some of the challenges as well as the assets that have been built around the work that you've done around HIV outreach?
I think it's, I see our work as really health education and health justice. If you're a gay or lesbian person or bisexual transgender, you basically come out in the bars. You go places where you can meet other people and where they feel relaxed, they have a few drinks, and then it becomes a habit, and then they come home. And if we're living in I'm Hispanic, right? If you come home to a Latino family, then you don't talk about certain issues. So that could be your sexual orientation, could be whether or not a person is depressed, or if you have a drinking problem. We learn to keep secrets in our culture. I remember as a child growing up, my mom saying, don't yell too loud because the neighbors might hear. It's like, okay, what are they going to hear? You know, but these are things that we're taught culturally. And so now we have situations where we have created an environment where we go out and party over the weekend, and there are no, the regulation on liquor stores and liquor licenses are very loose in California. So you can drink anywhere. We talked about baseball. I'm a Dodger fan.
Giant fan.
But the Dodgers probably have the worst policy.
Yes.
Because people go there to party and they get drunk. You go to other stadiums, I've been to 6 other stadiums, ballparks, you don't have that problem. And so, because alcohol sells and it brings in money to the owners, and so that's the injustice, right? And so when we live in a capitalist society, which I support, then the community needs to be engaged to leverage out the justice, right? And so that's what I really love, and my agency, my staff really loves that, is to see not only how we're taught to do prevention and education, but how do you change systems? That is a challenge, but that is what we really need to do. Did I answer your question?
Yeah, I mean, it's really fascinating also to explore some of these issues, because we heard a speaker earlier today. The question was, are there ways that you tailor messages that are culturally appropriate for a particular cultural group? And now and he actually said, well, I actually have a generic message that, takes into account your alcohol use. But you also referenced some historical basis. For example, a lot of people reference the first gay rights fight occurred in New York City at a bar, right? In terms of when people were busted. Can you tell us a little bit about how you think about this interface and whether there is aspects around the cultural challenges, alcohol use, the discrimination that LGBTQ communities face, and how you take the messaging around those two pieces?
Yeah, that's a great question. By the way, although you're alluding to Stonewall, Stonewall wasn't the first. It was a black cat here in Silver Lake was the first. Stonewall was the second.
Okay.
But I think it's important, why do people drink? That's the first question, right? I often tell people, why do you go to a dinner, a banquet, and there's a cocktail hour? Well, it's not, it's a cocktail hour because people need to go to unwind, right? Because they're so amped up. We in our community, in the LGBTQ community, for many people, that's the only space that people can go to and feel like they're wanted. We have such a high incidence of suicide in our community, such a high incidence of drug use, of abandonment, right? And so to self-medicate, that's what we do. And you go to gay prides around California, LA is probably the worst because it's alcohol driven, it's sponsorship driven. San Francisco has a wonderful gay pride, right? Because it's more generic, more holistic. So culturally, we have a lot of teaching. We need a lot of engaging and empowering the community to raise their voices. In the Hispanic community, I think it's about being honest and being truthful. I think the best educators in any community is our family members who have gone through alcoholism or bouts of alcoholism or have been victims of those alcohol and drug use. They need support. They need a place for their voice, and they need a place to influence the other members of family. And if they do that, then you influence the community, right? And so, there's a challenge, but I think it's really important that we validate people's spirits when we address these issues and provide outlets for where they can go to speak their mind, to seek mental health issues, and even seek substance use treatment.
Thanks, Richard. You know, Sandy, when we were talking to Richard here, it struck me about the work that you do and the messaging with families. And also this whole issue about, he didn't say it explicitly, but I heard stigma, okay? And I wondered in your work, when you reach out to families about things that weren't explicitly about alcohol, you mentioned secondhand smoke. Can you tell us a little bit about some of the special messages, what you have found effective in terms of making these links about, as Richard said, health justice?
When we provide our messages, it's really designing on listening to what that family member is talking about, right? So as we start to engage in that conversation, we don't talk about the health impact of it. We talk about what's happening with you and what do you see that's going on, and allow them to tell us what they need and where they're at, right? So really, just like for an example, talking about the alcohol, a father that is an alcoholic, how is that impacting you? What do your children think? How do you feel about it when they're drinking in the other room? Is that going to increase stress levels at home? How do we handle that? Allow them to share their stories for us to help them kind of process that a little bit. And then also when they're sharing their stories, is making it vocal where we can get help for them and connecting them to like services, but really empowering them where they're at and not to be ashamed or stigmatized, or I can't tell anybody because, you know, they're going to take my kids away. They're going to judge me. They're not going to know that I'm a good parent. So really allowing them to share their stories and then be able to design a way for them to get the services that they need, as well as empowering the message for them.
This thing about messages, in your experience, what do you think is some of the more effective ways of communicating that message to the families you care for?
For our office, we have multiple ways of doing it. We actually have an in-house radio station. So bringing in families that to share what's going on in their life, day-to-day life. So our community hears that they're not the only one that's dealing with something. For my radio show, I bring in a lot of guest speakers to be able to talk about subjects that are sensitive and that they're willing to give resources and be able to create this, like, it's okay for us to talk about it. And it's okay, there are services out there for us. And how can we empower them and get them help?
It's, that's fascinating. Can you think of a particularly powerful message that any one of your families shared for this larger audience that seemed to really strike a chord with people and motivated other families to take on issues or become active?
Well, with alcohol justice, we actually helped do the stop billboard ads on the bus stops. So we created a image and of a young child next to on a bus stop with an alcohol ad right next to them. And we talked about that. So those kind of powerful images shared understanding that that message is telling that child it's okay to drink and to be comfortable with alcohol ads. And then we went into the stores. On top of that is really looking at all the alcohol messaging that was out there that's impacting our kids. And right now, the big thing is social media. So social media, our kids are scrolling, even adults, our cell phones tell us how long we've been on the phone looking at social media, right? So there's constant messages telling you that alcohol is okay, and that's going to help me, and I'm going to feel better, and I'm going to be liked by my friends more because I am drinking alcohol and promoting a specific type of alcohol, right? So and that goes for all age groups. Think about it. I mean, we just had the big, festival. I always have a hard time pronouncing the word. Coachella. I always have a hard time, but all of them go with the idea of I need to get drunk to have a good time.
Mm.
And it's all on social media. It's constantly giving them that message that alcohol is the solution to everything. Lack of friends, to have fun, to be light, to be more relaxed. And it's the only way to do it, to have life.
Cruz, you described the canal and the discrimination that goes along with socioeconomic status. Along this line, what do you think are some of the special circumstances that you consider with regards to working with and messaging the members in your community of the canal?
So I think the special circumstances for us, and we've come across this a lot, is one, it's meeting folks where they're at, right? Like you had just talked about, Sandy, that we see a lot of these families that aren't truly aware of what's truly taking place in their background or in their backyard, literally because of the time constraints or the family household constantly working, so they don't have that connection with their families. They're working 2 to 3 jobs. So there's all these barriers that come within these circumstances that families aren't able to become a strengthened unit when it comes to being able to understand the realities of life that are taking place when they're not all together. And so one of the biggest things we've seen and that has helped us really promote that message of being able to understand their surroundings, being able to educate the community, is holding sessions within our office of speak sessions to have them be able to speak what's taking place, what's holding them back, providing that care at the first connection point with a lot of these families that we're working with. And I refer to the family component because in the canal, that's who we're connected to the most, because statewide as an organization, we have Raul as our advocacy director out here in LA. He's doing an amazing job, fabulous job with working with our legislative folks, being able to look at bills that we're either opposing or if we're not opposing it, we're supporting it with a letter of support. So there's all these communities that we're working with statewide that are allowing for us to truly understand where we need to meet the communities that we're working with on a day-to-day basis. So there's so much work that goes into what alcohol justice is doing across the state that this is where, we always have to kind of scale it back to talk about what we're doing in Marin because that's where our home base is at. But we're all over the state on a day-to-day basis promoting that message as well.
So Richard, I'm curious, you've worked with both of our colleagues here and you just heard Cruz describe some of his work. What's your reaction to how that work has been approached and how your work is similar or maybe different from what Cruz describes?
I think the work they have done has been amazing, because it's speaking to the people. But, I think, and the messaging, the questions around message is awesome, but I think we would really need is action. We really need action. It's when COVID hit us, everybody, went to masks, they stayed home. When George Floyd incident took place, everybody protested, everybody was concerned. But when people are getting killed by drunk drivers, and when people are constantly getting, overdosed on drugs, I don't hear that cry from community. And, we have to hold our legislators accountable. We collectively, and a number of organizations fought the late bar bill where the Sacramento wanted to extend the drinking hours till 4 o'clock in the morning. And I approached one of the co-authors here, Assemblyman Miguel Santiago. Why did you co-sign that? Well, because people need a place in LA to party after 2 o'clock. And I told him that was wrong. That was wrong, and he did not have an understanding of our community, nor was he responsible for our healthcare. And so I think people need to activate. People need to hold their elected officials accountable. If they don't like that what's going on, they need to then let them know and vote them out of office. I don't care if they're Democrat or they're Republican, and I don't care if they're conservative or progressive, because when it comes to justice in human life, there's only one thing to do. Kick them out of office and get people in there that understand our community. You know, I think this room is incredible. And we have a lot of solutions, but we need to be empowered to move forward and hold people accountable and know that we are leaders. And being a leader is 24 hours a day. It's not only 8 hours a day. And so that would be my message. That's a message that we talk about from our organization. Sometimes elected officials don't like hearing that, but too bad. Because, you know, at the end of the day, they're only there for 4 years or 8 hours, and then they're out if they're lucky. We're here forever.
Yeah, in California, we have term limits too in the assembly.
And then they look for where else are they going to go to work?
Yeah, yeah. So I'm just going to open up to the audience in a second. So I want you to come up with your questions. But Cruz, listening to Richard, if you could make something happen tomorrow to make a difference in the canal with regards to alcohol education and outreach, what would you do?
So it's just like Richard said, it's electing the right folks to the city council and supervisor level. This is what we're coming across the board. It's interesting because I had the conversation with Richard, that he should run. And so if he runs for an elected position, he's your go-to guy for this.
Yes.
But at the end of the day, it really comes back down to obviously the politics 101. And, interesting story, and I'll just say this real quick. The first time I stepped into my role at Alcohol Justice, stepped into the state capitol. And when I walked in, because when we write letters to legislative assembly, Congress, or senators, we usually don't get a good response. So until we testify at the state level. But when I walked in with Santiago as the chair at the time, he just, he looked at me and he said, "Oh, so you're the new executive director for Alcohol Justice." And that was it. You're the new executive director. So it really kind of goes back to, yes, we've tried to take a different approach, which I've always said it's taking the humanistic approach and really trying to agree to disagree. But at the end of the day, when folks aren't understanding the difference between sympathy and empathy and learning the true definition of that, it's not till they truly empathize with what folks are going through, then they're truly going to understand that change needs to take place. And when they leave their office, their building, they go to what is considered normal for them. But are they truly understanding that they continue to normalize drinking, but that's not a normalized effect to be taking place? The fact that we're able to walk across, and here in LA, we see folks that have spirits in their hands, alcoholic beverage in their hand, and we just walk past it like it's normal. And that we don't even stop to do anything about it. So that's the biggest normalization that we've failed as a society, that we're not doing better on. And that includes us as organizations, right?